And with me, I'm today is
Assalamu alaikum everyone. I am Feras Namour and welcome everyone to our upper limb crash out course, inshallah. We will cover hopefully everything upper limb, I believe.
inshallah.
And this, we're not going to cover brachial plexus or upper limb injuries specifically because that's a part on its own. But everything, anatomy, everything, blood supply, everything, muscles, it's all under here,
Yeah,
inshallah.
inshallah.
Bear with us. It's going to be very long. يعني we'll try to make it as ما حنحاول ما ناخذ كثير من وقتكم. We'll try as best as possible. Best, it's a lot of content to cover. So, before we start, we just want to say special thanks to these people who made everything possible. أكيد, there's me and Ahmed who primarily worked on all this. بس كمان the following people helped out in many different ways. Yazan is hosting and he helped us with some transcriptions. Yazan, bear with us. This could take a while. Bilal Daboul shared with us his Ambos account, and we have amazing diagrams to show you guys. And Yahya Mitwalli and Yahya Al-Ghabairi, both of them, both Yahyas helped us out with diagrams, tables, and transcriptions. And what did Saad do?
Saad,
Yeah.
I don't know.
Yeah, just shout out,
Yeah, it's shadow Saad.
So
Okay.
here's our socials. If you guys want to ask us anything after this crash course, feel free to on, don't worry. And this is what we're gonna cover now. We remove the sidebar. Right. So we covered these lectures, which is all of upper limb. Ahmed will start and kick it off. He will explain these 4 lectures, which are basically the shoulder area and the upper arm, or the arm region, really. And then I'm gonna take over and explain the forearms and the hand. Without further ado, we can start.
Yalla, let's get started.
So see you guys in the future. Bye.
Okay. Bismillah. So we'll start breaking down the regions from the top. So from the very beginning, we'll start with the shoulder girdle. So the very beginning of the shoulder girdle, so let's start with this flat bone here. We have this flat bone which is articulating with the acromion of the scapula and the manubrium of the sternum. So this flat bone, we call this the clavicle. Now the clavicle has 2 ends to it. It has a round end and it has a flat end. The round end articulates with the sternum, specifically the manubrium of the sternum. And the flat end primarily articulates with the acromion, and the acromion is a lateral bony projection which comes off the scapula. And we'll speak about all the landmarks later. Okay, so the articulation of the clavicle and the sternum makes a joint called the sternoclavicular joint. And the sternoclavicular joint is a saddle joint. As a synovial joint and it's saddle. And saddle joints are typically quite mobile, but the sternoclavicular joint is not so mobile because we have many strong ligaments supporting the sternoclavicular joint, and they're very strong. So it makes mobility very hard of this joint. So we have extrinsic ligaments and we have intrinsic ligaments, and we have a joint capsule. The extrinsic ligaments consist of the interclavicular ligament and the costoclavicular ligament, and the intrinsic ligament consists of the anterior and posterior sternoclavicular ligament. So by the way, guys, this lecture is very, or our PAL is very picture-based. So we'll have pictures and we'll have slides of everything we said, basically. So this is everything I said, but in words. Okay, now a certain pathology arises when we have trauma to the sternoclavicular joint. So if you look on this imaging, here we can see the clavicle clearly articulating with the sternum. But this clavicle here is dislocated and it's pulled posteriorly. Now the clavicle is pulled posteriorly because we have neck muscles, and these neck muscles pull the clavicle back. Now behind the clavicle, behind the sternum, we have very important structures. We have vasculature, whether it be the subclavian vein, artery, and we have also the trachea and the esophagus. So in a sternoclavicular joint dislocation, it's pulled posteriorly because of the neck muscles, and the patient would present with symptoms like difficulty speaking, breathing, difficulty swallowing food, for example. Okay, this is the clavicle. So this is the clavicle if we're looking at it superiorly. We have 2 ends to the clavicle. We have the medial end which is the rounded end, and it articulates with the sternum. And we have the lateral end, which is flat, and it articulates with the acromion. So superiorly, when we look at the clavicle from a superior view, it's very smooth compared to when we flip it and look at it from an inferior view. Now that's because right above the clavicle, what is there? There's skin. So if it was rough and had tubercles and stuff, it would damage the skin. So the superior surface of the clavicle is smooth, and the inferior surface, where all the muscles and ligaments attach, is rough. Now we have two important landmarks on the inferior surface. We have the conoid tubercle, and we have the trapezoid line here. Let me get the next diagram. So the conoid tubercle articulates with the conoid ligament, and the trapezoid line articulates with the trapezoid ligament. And the trapezoid ligament and the conoid ligament together make the coracoclavicular ligament. So on the scapula, we have something called the coracoid process. The coracoid process has a ligament which attaches to this to these two landmarks. And again, if you want to, so on the OSPI, they'll probably bring like or they might bring a picture in the MCQs saying identify this landmark, and you can, or identify which clavicle is this, and you can orient yourselves by looking at the end. The lateral end or the acromial end is very flat, whereas the sternal end or the medial end is very rounded. It's like a ball. Oh, and okay, this is an X-ray, and on the X-ray we can see a fracture. So the most common site of fracture in the clavicle is the junction between the medial 2/3 and the distal 1/3. And the clavicle, when it fractures, one part is pulled up, one part is pulled down. Now, the part that's pulled up is because of the sternocleidomastoid and other neck muscles that, due to unopposed strength, it pulls up the proximal fragment of the fracture. So you can see this part here, the proximal fragment of the fracture is being pulled up, and that's because of the sternocleidomastoid mainly. And this fragment, the inferior fragment, is just being pulled down by gravity. Okay. Now, the clavicle, it articulates with the sternum. It also articulates with the acromion. And so this forms the acromioclavicular joint. And we have many ligaments surrounding the acromioclavicular joint. So this first ligament here, we call this the conoid ligament. And we said the conoid ligament articulates with the conoid tubercle. And here we have the trapezoid ligament, which articulates with the trapezoid line. Now these two structures together, so the letter B, makes one big ligament we call the coracoclavicular ligament, okay? Can you see this? So first of all, this big triangular shaped bone here is the scapula. And we have a bony projection coming out anteriorly. We call this the coracoid process. So the coracoid process articulates with the clavicle through the coracoclavicular ligament. Okay. And so 1 and 2 are just muscles. And we have one more ligament. We call this the coracoacromial ligament. So the acromion is a lateral projection of the scapula. And this coracoacromial ligament, it connects the coracoid process and the acromion. And yeah. Here, we have a dislocation of the acromioclavicular joint. And essentially, when the ligament connecting the acromion and the clavicle tears, the clavicle would be pulled up. So this is an X-ray of an acromioclavicular joint dislocation. And wait. Okay. So this is an X-ray of an acromioclavicular joint dislocation. And clinically, in a clinic, you would see a little bump on the shoulder like this. This is a normal. So this is an acromioclavicular joint dislocation. Now moving on to the scapula. The scapula is a flat bone and is triangularly shaped. And the scapula has many landmarks. So we'll start off with the anterior view. So this is the lateral border of the scapula. This is the medial border. And here we have the suprascapular notch. And running through the suprascapular notch, we have the suprascapular nerve and artery. This bony projection, we spoke about it before. it comes out anteriorly from the scapula. We call this the coracoid process. And coming out laterally from the scapula is the acromion. If we look at a lateral view here, there's a socket here. And this socket articulates with the humerus. We call this the glenoid fossa. And above and below the glenoid fossa, we have tubercles, supraglenoid tubercle and infraglenoid tubercle. And these tubercles serve as attachment points for important muscles we'll talk about later. Now, if we look at the scapula posteriorly, we have an important landmark here called the spine of the scapula. Now, the spine of the scapula is an important landmark to differentiate between important muscles we call the rotator cuff muscles. Above the spine of the scapula, you'd see the supraspinatus, below infraspinatus. I'll speak about it later. And in the scapula, you have multiple fossa. So on the anterior surface, you can see this is a fossa. We call this the subscapular fossa. And if we look posteriorly, above the spine of the scapula, we have the supraspinous fossa. And below the spine of the scapula, we have the infraspinous fossa. Yeah, these are the landmarks. Now, the shoulder joint is a synovial ball and socket joint, and is formed by the articulation of the head of the humerus and the glenoid fossa of the scapula. Now, the shoulder joint, so the glenoid fossa actually isn't that deep, right? So if we only had the glenoid fossa to articulate with the humerus, dislocation would be very easy. But we have a very important structure to help with the articulation of the humerus and the glenoid fossa. It's called the glenoid labrum. Now, the glenoid labrum is a fibrocartilaginous structure, and it deepens the socket. And by deepening the socket, you make the articulation stronger and you prevent easy dislocations. And what else supports the shoulder joint? Other than the glenoid labrum, we have the rotator cuff muscles, which is the major supporter of stabilization and mobility and just structural support in general. We have the joint capsule, and as I mentioned, the labrum. And I think, yeah, okay. This is just everything in words. Okay. We have many important ligaments surrounding the shoulder joint to prevent it from dislocating. So anteriorly, we have the glenohumeral ligaments, and there are 3 different glenohumeral ligaments. We have superior, middle, and inferior. And sitting on top of the glenohumeral ligaments, we have the coracohumeral ligament. Now, sitting between the greater tubercle and lesser tubercle of the humerus, we have a ligament. We call it the transverse humeral ligament. And yeah, that's it actually. Okay, now this is the X-ray of the shoulder joint, and it's really important you're able to identify all the structures here. So let's start here. This is the clavicle. The clavicle articulates with the acromion process, or the acromion, which comes off the scapula. So if we follow this margin here, this is the superior border of the scapula. This is the medial border, and this is the lateral border. Now, this bony projection coming up and out of the scapula is called the coracoid process. And we can see something like a hole articulating with the head of the humerus. We call this the glenoid fossa. And this is obviously the head of the humerus, and this is the rest of the humerus. We'll talk about it later. So it's important you identify all important landmarks on an X-ray so you can identify any pathologies. So observe the orientation of the head of the humerus and the glenoid fossa. See how it's articulating and how it kind of overlaps with the glenoid fossa, right? Now in this location, so here again, the head of the humerus is overlapping with the glenoid fossa on the X-ray. Here, the head of humerus is not in place. It's overlapping it more than usual. You can see it's coming out and down. And this is an anterior dislocation of the humerus, of the shoulder joint. Now, if you look here, this is a normal X-ray. And again, we can see the head of the humerus overlapping with the glenoid fossa. However, here, we can clearly see the glenoid fossa. And we can clearly see that the head of the humerus is no longer articulating with the glenoid fossa, and it kind of resembles a light bulb. We call this posterior dislocation of the humerus. Okay, now the major stabilizer of the shoulder joint are the rotator cuff muscles, and we have 4 rotator cuff muscles. So anteriorly, we have the subscapularis. It sits in the subscapular fossa of the scapula. And posteriorly, first let's identify this anatomical landmark. We call it the spine of the scapula. Above the spine of the scapula, we have the supraspinatus muscle. Right below the spine of the scapula, we have the infraspinatus muscle. And below the infraspinatus muscle, we have the teres minor muscle. Now, these muscles, it's not here, but these muscles form a tendinous cuff around the shoulder joint, and it covers it anteriorly, posteriorly, and superiorly. Now, this leaves some weakness inferiorly. So if you guys abduct your arm and externally rotate, you notice that your shoulder goes down. So the head of the humerus actually slips under the glenoid labrum, and it's because the tendinous cuff doesn't cover inferiorly. It's weaker inferiorly. Again, this is just rotator cuff muscles. So above the spine of the scapula, we have supraspinatus. Below the spine of the scapula, we have the infraspinatus. And below the infraspinatus, we have the teres minor. And if we look anteriorly, this muscle covering the whole scapula is the subscapularis. Now, the shoulder muscles. So again, in the beginning, I think we mentioned we don't need to know origins or insertions. But if you know the origins and insertions, the actions of the muscles will make sense. So the deltoid originates from the lateral end of the clavicle and the spine of the scapula, and it inserts onto the lateral shaft of the humerus. So when the muscle fibers contract, they will bring the arm up. So the action of the deltoid is abduction of the arm from 15 degrees to 90 to around 100 degrees. So it doesn't start abduction, it continues abduction from 15 degrees to 90 to 100 degrees. And what nerve innervates the deltoid is the axillary nerve. And you need to know the roots of the axillary nerve, which is C5, C6. Now, above the spine of the scapula, we have the supraspinatus muscle. The supraspinatus muscle comes from the supraspinous fossa, and it inserts itself on the superior point of the greater tubercle of the humerus, at this point here. So the greater tubercle is very lateral, whereas the lesser tubercle is medial. So inserts laterally on the superior point of the greater tubercle of the humerus. So when the muscle fibers of the supraspinatus contract, they will bring the arm or the humerus up. So the role of the supraspinatus is to initiate abduction from 0 to 15 degrees. And it's innervated by the suprascapular nerve, which is C5, C6 as well. Now, what's the difference between the supraspinatus and the deltoid? The supraspinatus starts abduction. So if your supraspinatus is damaged, when your arms are at rest, you won't be able to abduct. But if you lift your arms up at a 90-degree angle and you ask the patient to abduct, for example, they'll be able to abduct because their deltoid is still intact, whereas their supraspinatus isn't. So it's important to differentiate.
Take it lower, bro.
Hello.
Okay. It's important to differentiate that the supraspinatus initiates abduction and the deltoid carries on abduction from 15 to 90 or 100 degrees. Now the infraspinatus sits below the spine of the scapula, and it originates from the infraspinous fossa. And it inserts itself on the middle point of the greater tubercle of the humerus. So when the muscle fibers contract, you can see that it would pull the humerus outwards, kind of. So the main role or action of the infraspinatus is lateral rotation of the arm. And just like the supraspinatus, it's innervated by the suprascapular nerve, which is C5, C6. And just a fun fact, you typically see infraspinatus injury in baseball pitchers. Guys who throw baseballs, if you don't know. The teres minor originates from the lateral border of the scapula, and it inserts itself on the inferior point of the greater tubercle of the humerus. So, again, it would laterally rotate the arm, like the infraspinatus, but the teres minor is innervated by the axillary nerve, which comes from C5, C6 again. And finally, we have the teres major, which, no, actually not finally, but the teres major comes from the lateral border of the scapula, and it inserts itself not on the lateral, but the medial border of the humerus on the bicipital groove, the groove between the two tubercles of the humerus. And the role of the teres major is to medially rotate the arm. And the teres major is innervated by the lower subscapular nerve, which is C5, C7. We have two subscapular nerves, upper and lower. So the lower subscapular nerve innervates the teres major, whereas the upper innervates the subscapularis, which I'll speak about now. The subscapularis originates from the subscapular fossa, and it inserts itself on the lesser tubercle of the humerus. And so when it contracts, it brings the arm inwards, or it medially rotates the arm. And again, the subscapularis is innervated by the upper subscapular nerve, C5, C7. So it's important you differentiate that the subscapularis is innervated by upper subscapular nerve, and the teres major is innervated by the lower subscapular nerve. And we'll just go over it one last time. So posteriorly, we have supraspinatus above spine of the scapula. It initiates abduction, from 0 to 15 degrees. Below the spine of the scapula, we have the infraspinatus and we have the teres minor, and both of these muscles laterally rotate the arm. And anteriorly, we have the subscapularis muscle, which sits on the subscapular fossa of the scapula, and it medially rotates the arm. This is just another view of the rotator cuff muscles. Supraspinatus, infraspinatus, teres minor. Anteriorly is the subscapularis. Below the acromion, we have an important structure called the subacromial bursa, which I'll speak about now. Okay. The subacromial bursa acts as a cushion for muscles and ligaments. And so it's a fluid-filled sac, essentially, and it acts like a cushion. So without the subacromial bursa, you'd have friction and damage to the muscles and ligaments of the shoulder joint, of any joint. So there's a certain pathology that happens with the subacromial bursa. We call it subacromial bursitis, which is essentially inflammation of the subacromial bursa. So the subacromial bursa, it sits underneath the acromion and right above the head of the humerus. And essentially, if we have inflammation to the subacromial bursitis, it can cause supraspinatus tendinitis. Now, there's no telling in what comes first without a good patient history. So if a patient comes to your clinic and they've had an infection, for example, or they have trauma to their shoulder, it could be subacromial bursitis because infections easily travel to bursa. And subacromial bursitis, the bursa is very intimate with the supraspinatus tendon. So when you have inflammation of the subacromial bursa, it leads to inflammation of the tendon of the supraspinatus muscle. But on the other hand, you could have osteoarthritic changes, and this could lead to calcific tendinitis of the supraspinatus tendon. And because of the inflammation of the supraspinatus tendon, the subacromial bursa itself would be inflamed. So supraspinatus tendinopathy can lead to subacromial bursitis, and subacromial bursitis can lead to supraspinatus tendinopathy. This is an MRI. MRI is generally used to observe soft tissue. So here is the supraspinatus muscle, and this is the tendon attaching to the greater tubercle of the humerus. And here we have the acromion, and right below the acromion, sitting above the supraspinatus and the humerus, we have the subacromial bursa. So when if you had inflammation of the supraspinatus tendon, the subacromial bursa would get inflamed and therefore subacromial bursitis. And so these generally come hand in hand. And an important buzzword you should know is painful arc of abduction. So a patient will come complaining of frozen shoulder, and when they try to, there's a certain angle, I'm not sure the angle, it wasn't mentioned, I think between 60 and 120.
Probably, yeah.
Between 60 and 120 degrees, they're not able to abduct, or it's very painful. And this is a buzzword for supraspinatus tendinopathy.
Yeah. So like, for example, when they want to comb their hair or do other like
take something from the top shelf, it will hurt.
Yeah,
So
so
that's how in a clinical scenario it will change.
so what Feras said, I don't know if they heard. Essentially, when they try to reach for things above their head, try to comb their hair, try to reach for shelves, for example, it would hurt. That's how it would present clinically. Okay, moving on to the humerus. The humerus has many landmarks. So we'll start with the very top. We have the head of the humerus. The head of the humerus articulates with the glenoid fossa, and this forms the glenohumeral joint or the shoulder joint. Right below the head, we have this imaginary line, and it's called the anatomical neck. And sitting right next to the head of the humerus, we have two tubercles. So sitting most laterally is the greater tubercle, and sitting most medially is the lesser tubercle. And in between the two tubercles, we have something called the intertubercular sulcus, or the bicipital groove, which I'll be calling for the rest of the session. Bicipital groove. And this imaginary line here is important clinically. It's called the surgical neck. And the surgical neck is the most common site for fracture. Yeah, Feras will cover this, it's fine. So the greater tubercle, so we said the rotator cuff muscles, they attach to the tubercles of the humerus. Now the greater tubercle serves as an attachment point for the supraspinatus, the infraspinatus, and the teres minor. And the lesser tubercle, it serves as an attachment point for the subscapularis. So you can remember this using sits. So your thumb is the subscapularis, your index, middle finger, and ring finger are supraspinatus, infraspinatus, teres minor. The supraspinatus, infraspinatus, and teres minor, they all attach to the greater tubercle, whereas the subscapularis attaches to the lesser tubercle. Bicipital groove. Okay, this is an X-ray of the landmarks of the humerus. So here we have the head of the humerus articulating with the glenoid fossa. We have the greater tubercle sitting most laterally, and the lesser tubercle sits more medially. And we have the surgical neck, which is just below, and it's the most common site for fracture. Here we have the shaft of the humerus. You don't need to know, it's a fun fact. It's more for OSPE, but the deltoid actually attaches. There's a tuberosity here where the deltoid attaches. Okay, this is a fracture dislocation. So remember the surgical neck. We said it's the most common site for fracture. And here we're observing a surgical neck fracture. And sometimes with a surgical neck fracture, we can have dislocation of the head of the humerus. So it can either move posteriorly or anteriorly. Now there are two important structures which are very intimate with the surgical neck of the humerus. They wrap around the surgical neck. We have the axillary nerve and the posterior circumflex humeral artery. So when you have a surgical neck fracture, always think of these two important structures. You could have disruption of the arterial supply and therefore necrosis of the rest of your arm, or you could have paralysis of your deltoid, so inability to abduct above 15 degrees and loss of sensation over your shoulder. Okay, it's 3:34 and it's Asr right now, so we can have a break for 5 minutes. I'll come back at 3:40, inshallah. Okay, let's continue. So, 1 second. Now we have the axilla. So the axilla is defined by many different boundaries. We have the apex, anterior wall, posterior wall, lateral wall, lateral wall, medial wall, and the base. So the apex is formed by rib 1, the clavicle, and the very tip of the subscapularis muscle. And the base of the axilla is formed by tissue, skin, fascia. Not relevant. It makes sense. Now the anterior wall is formed by the pectoralis major and pectoralis minor muscles. And the posterior wall is formed by the latissimus dorsi, the teres major, and it's formed by the latissimus dorsi, teres major, and subscapularis muscle. The medial wall is formed by the ribs and the serratus anterior, And the lateral wall is formed by the bicipital groove of the humerus. I have a better diagram here to visualize for you. So anteriorly, we have the pectoralis major and pectoralis minor. Medially, we have the serratus anterior. And posteriorly, you can't really differentiate, but you have the latissimus dorsi, teres major, and subscapularis. And this is the humerus and the bicipital groove of the humerus. This is everything I said. Now the vasculature of the axillary region will start from the arch of aorta. So from the arch of the aorta, we have the brachiocephalic trunk. The brachiocephalic trunk branches off into two. We have the right common carotid and the right subclavian. Now the right subclavian, it forces, and then it becomes the axillary artery when it passes under the clavicle, the first rib, when it passes over the first rib. Now, the axillary artery has three main branches. Three parts, and each part has branches. The first part has one branch, the second part has two branches, and the third part has three branches. So the first part is the superior thoracic artery. The branch is the superior thoracic artery. And the second branch, second part of the axillary artery, we have two branches. We have the thoracoacromial artery, and the thoracoacromial artery has many different branches. It has the pectoral branch going to the pectoral region, clavicular, acromial, and deltoid. They're all in the name. Now we have the lateral thoracic artery. The lateral thoracic artery is very intimate with the long thoracic nerve, and the long thoracic nerve innervates the serratus anterior. So if you have damage to the lateral thoracic artery, it would typically damage the long thoracic nerve, and you'd have the typical presentation, which is winged scapula. Now, the third part of the axillary artery it has three branches, the anterior and posterior circumflex humeral arteries. Now, the anterior doesn't really contribute much to blood supply. The posterior is very important because it's very intimate with the surgical neck of the humerus. And we have one more branch, the subscapular artery. And the subscapular artery is very important for the anastomosis I'll explain in a bit. And coming from the subscapular artery, we have the thoracodorsal artery, which is intimate with the thoracodorsal nerve, which innervates the latissimus dorsi. And we have the circumflex scapular artery, which contributes to the anastomosis of the scapula. And the continuation of the axillary artery is the brachial artery. So the arterial anastomosis is actually not that hard. So we have the subclavian artery. When it passes under, it becomes the axillary artery. And by the way, the axillary artery, it's divided into parts relative to the location of the pectoralis major. So the first part is the most proximal to the pectoralis, minor. The first part is the most proximal to the pectoralis minor, whereas the third part is the most distal to the pectoralis minor. Okay, now the anastomosis is clinically important because it assesses the urgency, helps you assess the urgency of a situation, and it helps you with blood flow, understanding blood flow, and where to place ligatures and stuff during surgery. So the subclavian artery, the first part of the subclavian artery, has a branch, and this branch is called the thyrocervical trunk. So the thyrocervical trunk branches off, and the thyrocervical trunk itself has two branches. It has the transverse cervical artery, and it has the suprascapular artery. Now let's move on to the third part of the axillary artery. So we said from the third part, we have the anterior circumflex, posterior circumflex, and we have the subscapular artery. Now the subscapular artery branches off into circumflex scapular arteries and thoracodorsal. The circumflex scapular artery is what contributes to the anastomosis. So from the subclavian artery, we have thyrocervical trunk. From the thyrocervical trunk, we have suprascapular artery, which contributes to the anastomosis. And then from the third part of the axillary nerve, we have the subscapular artery. From the subscapular artery, we have two main branches. We have thoracodorsal and we have circumflex scapula. And circumflex scapula is what mainly contributes to the anastomosis. Now, if we had a blood clot, for example, form between the first or second part of the axillary artery, it would be fine. Why? Because we have anastomosis with the thyrocervical trunk and the suprascapular artery and the subscapular artery and the circumflex scapula. So anything blocked in between would just be compensated by the anastomosis. But if we had a clot distal to the subscapular artery, let's say around here, after the subscapular artery, it would lead to disruption of blood flow to anything below the axillary artery, and therefore it would lead to necrosis, you'd need amputation, etc. So anything distal, any obstruction or disruption to blood flow distal to the subscapular artery would lead to necrosis of the rest of the arm. Now, venous drainage. So the axillary vein receives three main tributaries before becoming the subclavian vein. So first, the axillary vein itself is continuous with the basilic vein. And the basilic vein runs on the medial border of the arm and the forearm. So the basilic vein runs up on the medial border of the arm and forearm, and then it joins with a vein that is quite central. This vein is the brachial vein. So the basilic vein is continuous. It goes up the medial border of the arm and forearm, and then it joins with the brachial vein joins onto the basilic vein. And now up here, we have one more tributary, which is the cephalic vein. Now the cephalic vein runs on the lateral border of the forearm and arm, and it joins onto the axillary vein. And then, yeah, that's it really. So the axillary vein is continuous with the basilic vein. Cephalic vein joins onto basilic vein. And then cephalic vein joins onto axillary vein. And then axillary vein, when it travels under the clavicle, it becomes the subclavian vein. Okay, moving on to the muscles of the axilla. We'll start with the pectoral region. So the first muscle is the subclavius, and it originates from the first rib and costal cartilage, and it inserts itself on the inferior surface of the clavicle. Now it's in the name, subclavius is under the clavicle, and it inserts on the inferior surface of the clavicle. Therefore, we'd expect the subclavius to depress the clavicle, bring it down when it contracts. And the subclavius is innervated by the nerve to subclavius. It's not important. Now we have the big muscle, the pectoralis major, a fan-shaped muscle, and it originates from the medial half of the clavicle, and it inserts itself on the lateral lip of the bicipital groove of the humerus. Okay, so you can see the different array of fibers of the pectoralis major. So when the pectoralis major contracts, you'd expect to have flexion or a deduction and medial rotation of the arm. Again, flexion, bringing the arm up, a deduction, bringing the arm towards the midline, and medial rotation of the humerus or the arm. And the pectoralis major is innervated by the lateral and medial pectoral nerves. Again, it's in the name, it's kind of common sense. We have the pectoralis minor. The pectoralis minor originates from the third and fourth rib, and it inserts itself on the coracoid process. So you'd imagine that because it inserts itself on the coracoid process, it would pull the scapula towards the thoracic wall. So the action of the pectoralis minor, when it contracts, it stabilizes the scapula against the thoracic wall, and it drags it inferiorly and anteriorly. And again, the pectoralis minor is innervated by the lateral and medial pectoral nerves. And finally, for the pectoral region, we have the serratus anterior. The serratus anterior originates from the upper 8 ribs, and it inserts itself on the medial border of the scapula. So, because it inserts itself on the medial border of the scapula, when it contracts, it brings the scapula in, it protracts the scapula. And also, we said the supraspinatus initiates abduction from 0 to 15 degrees, the deltoid from 15 to 90 or 100 degrees. What's next? What helps us abduct the arm from above that horizontal level? We have the serratus anterior and we have the trapezius. So serratus anterior helps with abduction, moving the arm away from the midline above the horizontal level. So it goes supraspinatus, deltoid, and then serratus anterior or trapezius. And the serratus anterior is innervated by the long thoracic nerve. Now, this is clinically relevant because we have a condition called winged scapula. So sometimes when a patient comes with breast cancer, and typically the guidelines for treating breast cancer are a radical mastectomy or removing the whole breast. And a complication of that surgery is damaging the long thoracic nerve. And when you damage the long thoracic nerve, you paralyze the serratus anterior. So you tell your patient to go against the wall. They'd have to be shirtless, and you tell them to push against the wall. Their unaffected side, or the unaffected side would, you see the scapula protract. You see the scapula go inside. But the affected side, the scapula would bulge out. You can see here, it's bulging out. The serratus anterior is paralyzed. It cannot bring the scapula in and stabilize it. And also, they present with inability to abduct their arm above the horizontal level. They cannot abduct it above 90 to 100 degrees. Okay, now superficial muscles of the back. We'll start with the trapezius. The trapezius originates from this bony landmark called the external occipital protuberance, and it inserts itself on the spine of the scapula. Now, the trapezius has three sets of fibers. We have the superior fibers, the middle fibers, and the inferior fibers. Now, the superior fibers, when they contract, due to their attachment of the spine of the scapula, they pull the scapula up. The middle fibers, when they contract, they bring the scapula out. They retract the scapula. And finally, the inferior fibers, they're running down here. When they contract, they bring the scapula down. And the trapezius is innervated by a cranial nerve 11, the accessory nerve, specifically the spinal accessory nerve. The accessory nerve has two parts, cranial, spinal. It's the spinal accessory nerve. Okay. Levator scapula, it's in the name. So it comes from the transverse processes of C1 to C4, sitting all the way up here. And it inserts itself on the medial border of the scapula. And as the name implies, it elevates the scapula. And just a note to keep in mind, the levator scapula and the rhomboid major and rhomboid minor are all innervated by the dorsal scapular nerve. Okay? So levator scapula, elevate scapula, dorsal scapular nerve. Now we have rhomboid major, rhomboid minor. Now the difference between rhomboid major and minor is their location. Typically for any muscle in the body, minor is above major. And that's because minor is floating. I'm not sure why minor is always above. But anyways, rhomboid minor sits above rhomboid major. But rhomboid major is fatter than rhomboid minor. So rhomboid minor originates from C7 to T1, and rhomboid major originates from T2 to T5. And they both insert themselves on the spine and the medial border of the scapula. So you'd imagine when they contract, because of their attachment, they bring the scapula in towards the midline. They adduct the scapula. And they're innervated, as I said before, by the dorsal scapular nerve. So the levator scapula and the rhomboid major and minor are innervated by the dorsal scapular nerve. Finally, the latissimus dorsi, your lats basically, it originates from the spines of T7 to T12, and they insert themselves on the bicipital groove of the humerus. So this part here. So you'd imagine when they contract, again, they have many different fibers. When they contract, they can extend the humerus, they can adduct the humerus, or they can medially rotate it. Again, the latissimus dorsi, because of its insertion on the bicipital groove, it can extend the arm, bring it backwards here, adduct the arm, bring it towards the midline, and medially rotate the arm. And the latissimus dorsi is innervated by the thoracodorsal nerve, and the thoracodorsal nerve is very intimate with the thoracodorsal artery. And we said the thoracodorsal artery comes from the third part of the axillary artery. Okay, just a quick review. We have pectoralis major, subclavius, pectoralis minor. Subclavius depresses the clavicle, pectoralis major flexes, adducts, medially rotates the arm, and pectoralis minor stabilizes the scapula and protracts it. We have the back muscles. We have trapezius. Trapezius has three sets of fibers. Superior fibers elevate the scapula. Middle fibers retract the scapula. And inferior fibers depress the scapula. we have the levator scapula, as the name implies, it elevates the scapula, rhomboid minor and major. So rhomboid minor sits above rhomboid major, because minor typically sits above major, and rhomboid major is fatter than rhomboid minor, and rhomboid minor and major have the same action, which is to adduct the scapula. And finally, the latissimus dorsi, which we said inserts itself on the bicipital groove of the humerus. It is responsible for extension of the arm, bringing it back, a deduction of the arm, and medial rotation of the arm. Levator scapula, rhomboid minor, rhomboid major are all innervated by the dorsal scapular nerve, trapezius by the spinal accessory nerve, cranial nerve 11, and latissimus dorsi, the thoracodorsal nerve. Okay, now the spaces. Okay, so the muscles of the arm and the shoulder form spaces. We'll start with the quadrangular axillary space. So from what you can see here, the superior border is the teres minor, but this is posteriorly. There's a space anteriorly as well. So anteriorly, we have the subscapularis muscle, which sits as the superior border of the quadrangular axillary space. Posteriorly, we have the teres minor muscle. And medially, we have the long head of the triceps. And laterally, we have the intertubercular groove of the humerus. And inferiorly, we have the floor is the teres major. Okay, we'll say that again. The roof of the quadrangular space is the teres minor or the subscapularis. The medial border is the long head of the triceps brachia. The lateral border is the humerus, specifically the bicipital groove of the humerus. And the floor of the quadrangular space is the teres major. Something like this. Okay? And running through the quadrangular space is the axillary nerve and the posterior circumflex humeral artery. And we said these nerves are very intimate with the surgical neck. So any fracture of the surgical neck would of the humerus would lead to damage to the axillary nerve and posterior circumflex humeral artery. But also, if you have a pathology in the quadrangular space, for example, trauma or hypertrophy, for example, it could lead to damage to the axillary nerve and posterior circumflex humeral artery. This is a fracture of the surgical neck. Again, the axillary nerve and the posterior circumflex humeral artery are at risk of damage. The other spaces, we have the triangular space. The roof of the triangular space is formed by the teres minor, and anteriorly, we have the subscapularis. So roof, teres minor, if posterior and anterior, we have the subscapularis. The floor of the triangular space is the teres major. And finally, the lateral border of the triangular space would be the long head of the triceps. And running through the triangular space, we have the circumflex scapular artery. And this is important because we said the circumflex scapular artery comes from the third part of the axillary nerve, and it contributes to the scapular anastomosis. Finally, we have the triangular interval. The triangular interval, the borders are laterally the humerus, and medially the long head of the triceps. Actually, wait, no, sorry. Laterally is the lateral head of the triceps brachia, and medially is the long head of the triceps brachia. So triangular interval, laterally, lateral head of triceps brachia, medially, long head of triceps brachia. And running through the interval, we have the radial nerve and the deep brachial artery. And these structures are intimate with the midshaft of the humerus. So if you have a midshaft fracture of the humerus, the radial nerve and the deep brachial artery are at risk. So you'd have troubles with extending your arm, you'd lose sensation on the posterior surface of your arm, and you'd have profound bleeding, and possibly you'd see like a very big bulge of blood, a hematoma. And finally, for the axilla, we have the lymph nodes. So we have axillary lymph nodes, and they have 5 different categories: pectoral, apical, lateral, central, and posterior. Okay. Now, the most important lymph node you need to know here is pectoral. because when, for example, in the scenario of breast cancer typically metastasizes, and when it does metastasize, the first lymph node it affects is the anterior lymph node or the pectoral lymph node. So just know that the pectoral lymph node is the first to receive metastasis from breast cancer, and you can also call the pectoral lymph node the anterior lymph node. Finally, the arm, the upper arm. Just a quick recap of the brachial plexus. There's another pile on this, but just a quick recap. The lateral cord gives rise to the musculocutaneous nerve and the lateral part of the median nerve. The posterior cord gives rise to the axillary nerve and the radial nerve. And the medial cord gives rise to the medial part of the median nerve and the ulnar nerve. What we're concerned about is musculocutaneous and axillary and radial. Okay, so in the arm, we have flexors. What is flexion of the arm? Flexion of the arm is when you bring it up like this, okay? And in the flexor compartment of the arm, we have three main flexors. We have the coracobrachialis. Coraco, so you can infer that it arises from the coracoid process of the scapula. And coracobrachialis is essentially responsible for flexion of the arm and adduction of the arm. Now, a very famous muscle, the biceps brachii, its main action is actually not flexion. It's actually supination. So the biceps brachii is responsible for supination and flexion of the forearm and arm. So people who go to the gym, if you want to truly hypertrophy your biceps, you want to start off at a 45-degree angle and you want to supinate and flex at the same time. This will provide maximal muscle growth because the main action of the biceps is not flexion, it's supination. And finally, we have the brachialis, which is responsible for flexion of the arm. And all flexor muscles, the coracobrachialis, the biceps brachii, and the brachialis are innervated by the musculocutaneous nerve. The biceps brachii is called biceps because bi means two. It's called biceps because it has two heads. You have a short head and a long head. The short head attaches to the coracoid, it comes from the coracoid process, and the long head comes from the supraglenoid tubercle. So remember, we had the glenoid fossa. The glenoid fossa has a tubercle above and below, and we call this the supraglenoid tubercle and the infraglenoid tubercle. For the extensors, we have two muscles. Mainly is the triceps brachii. Triceps for three heads. Triceps brachii is responsible for extension of the arm, so bringing it back like this. And the anconeus is a muscle which sits just around your elbow joint. It helps the triceps in extending the forearm. And the extensor muscles of the arm are innervated by the radial nerve. And you need to know the roots. So the musculocutaneous goes from C5 to C7, and the radial nerve goes from C5 to T1. Okay, so a pathology you should know. If you, let's say you're in the gym and you're hitting preacher curls and you want to one-up your friend, you do 30 kg preacher curls. This is a very significant force for such a risky movement, and this would generally lead to a rupture of the long head of the biceps. So essentially what happens is the long head of the biceps, it attaches at the supraglenoid tubercle. When you apply too much force, it ruptures. It avulses from the supraglenoid tubercle. So what you would see is, so you can see here, it's demonstrated nicely. The proximal part of the long head of the biceps is ruptured, and it kind of slings down, right? So clinically, the patient would present with a bump like this. Their bump would be like very distal to their shoulder. So one cause of rupture of biceps tendon is exerting yourself against a significant resistance. And another cause is osteoarthritic changes. So osteoarthritis leads to some bone fragments forming around your joint. And this can lead to the bone fragments kind of like cutting your tendon, biceps tendon, and this would lead to rupture. So it's just a fun fact, but in osteoarthritis, you have formation of something called bone spurs, and these bone spurs act as like, they're very sharp fragments, and it can lead to rupture of the supraspinatus tendon. Oh, sorry, long head of the biceps. Okay, innervation. Innervation is quite simple. So the axillary nerve, we said the axillary nerve is responsible for innervating the deltoid and the teres minor. And so you'd expect the axillary nerve to provide sensation to the skin over the shoulder. Now we have the medial cutaneous nerve of the arm or forearm. As the name implies, it supplies the medial surface of the arm, but also the anterior surface. We have the musculocutaneous nerve. Now, although the musculocutaneous nerve provides innervation to the flexor muscles of the arm, it doesn't actually provide any sensation to the skin of the arm. What the musculocutaneous nerve does supply is the skin of the lateral forearm, not the arm. Finally, the radial nerve innervates the whole posterior arm, skin of the posterior arm. So this is the anterior surface. We have the axillary nerve over the shoulder. We have the radial nerve is coming around posterior. It's mainly posterior. Medial cutaneous nerve of arm and forearm. And we have the musculocutaneous, which is over the lateral forearm. And posteriorly, you can see it's mainly the radial nerve. So for vasculature, the main blood supply of the arm is the brachial artery. And the brachial artery has many branches. So the first main branch is the deep brachial artery, or profunda brachia. So the deep brachial artery is very intimate with the midshaft of the humerus. So again, when you have a fracture of the midshaft of the humerus, you'd generally have damage to the deep brachial artery, leading to a formation of a hematoma, right? Now, from up here, we have the superior ulnar collateral artery and the inferior ulnar collateral artery. The superior ulnar collateral artery branches off earlier from the brachial artery, and it runs posterior. And the inferior ulnar collateral artery branches off much lower, and it runs anterior. So superior runs posterior, inferior runs anterior. And finally, we have the terminal branch of the brachial artery, branches off into two, the ulnar artery and the radial artery, which my fellow colleague Feras will talk about. And Olena mentioned two other branches, nutrient branches to the humerus, so branches that supply blood and oxygen to the humerus, and muscular branches that innervate the muscles. It's not innervate, they supply the muscles. So this is a pathology we call Volkmann's ischemic contracture. So firstly, observe how there's visible atrophy. And secondly, there's a kind of forcible contraction of the wrist. Or it's flexed. The wrist is very flexed alongside the fingers. So this happens due to disruption of vascular supply. So we have a landmark in the humerus, the condyle, and when you have a fracture above the condyle, we call it a supracondylar fracture. Now the brachial artery is very intimate with the condyle, and when you have a supracondylar fracture, you damage the brachial artery. Now, because you damage the brachial artery, it would generally lead to hemorrhage, and this hemorrhage increases the pressure of the there's a fascia around the arm, and the fascia is enclosed, and the brachial artery runs through the fascia. Now, when you have damage to the brachial artery, you'd have hemorrhage, and you'd have increased pressure in the fascia. What else is in the fascia? You have muscles. So the hemorrhage leads to increased pressure, and the increased pressure leads to contraction of the muscles. Why? Because you're disrupting blood flow, and you're inducing pressure on the muscles. And because of this wombo combo, you induce ischemia. Ischemia leads to necrosis, and necrotic tissue has to be replaced by fibrous tissue. You have fibrosis. So the muscles are, you can say the muscles are forcibly contracted, but they're not really contracting. It's that they're so fibrosed that the fibrous tissue simulates contraction of the muscles. And Volkmann ischemic contracture is typically caused by supracondylar fracture, leading to compartment syndrome, or a very tight bandage or cast. Now we have the veins. So we earlier on we mentioned this, the basilic vein runs medially, and it receives blood from the medial border of the arm and forearm. Laterally, we have the cephalic vein. cephalic vein receives blood supply from the lateral arm and forearm. And as we said, the basilic vein continues on to become the axillary vein, receiving tributaries from both the cephalic and brachial vein.
Brachial or basilic vein?
Brachial.
Ah.
Okay. Finally, cubital fossa. So the cubital fossa, let's first define the borders. The cubital fossa has a superior, medial, and lateral border. The superior border is a line between the epicondyles. It's just an imaginary line. Medially, we have the pronator teres, and laterally, we have the brachioradialis. And my friend Feras will speak about these muscles, inshallah. So as we said, borders, superior, we have the line between the epicondyles. Medially, pronator teres, and laterally, brachioradialis, forming a triangle, okay? Now the floor of the cubital fossa on the lateral side is formed by the supinator. Now, the supinator is deep here. It sits laterally and it forms the wall of the floor of the cubital fossa. Medially, we have this muscle here. This muscle is called the brachialis. So the floor of the cubital fossa is formed by two muscles. Medially, we have the brachialis, and laterally, we have the supinator. The supinator you cannot see here because it's deep. And the roof is formed by skin, fascia, and the bicipital aponeurosis. What's the bicipital aponeurosis? So the biceps has a tendon, biceps brachii has a tendon, and when the tendon has an extension of fascia, and this fascia we call it bicipital aponeurosis. Now the contents of the cubital fossa is what we care about. Now we'll start with the deep contents. So from medial to lateral, we'll start with the median nerve. So remember the mnemonic MBBS. M is the median nerve. The median nerve sits most medially, hence the name median nerve. Right after the median nerve, you have the brachial artery. After the brachial artery, you have the tendon of the biceps brachii. And finally, you have the superficial branch of the radial nerve. So again, the deep contents of the cubital fossa, from medial to lateral, are the median nerve, the brachial artery, the tendon of the biceps brachii, and the superficial branch of the radial nerve. Again, here we can see the borders. So medially we have the pronator teres, laterally we have the brachioradialis, and superiorly we have the imaginary line between the epicondyles. Now it's important we know the contents of the cubital fossa, because when we want to collect blood, for example, we can collect blood from the median cubital vein. The median cubital vein sits bang center in the cubital fossa, and typically when you want to take blood, we penetrate the median cubital vein, which sits in the middle of the cubital fossa. And it's important that we take blood from the median cubital vein and we identify it, because if we go too deep, we might penetrate the brachial artery, and this is no bueno, not good. Okay, that's my part. Thank you very much for listening. If you have any questions, my contact details are in the beginning. And now it's my fellow colleague Feras' turn.
Okay. So, is there any questions? Thank you. Yeah. طيب. Thank you, Ahmed, for the amazing explanation. I'd like to continue from where he stopped. We're going to move on to the forearm, and inshallah, we'll finish with the hand. Hopefully, we won't take as long. Let's see. So in the forearm, we're going to discuss the same principles all over again. We're going to talk first about the bones. Then we're going to build on top of it the muscles, the innervation to each muscle, and the blood supply to the region. And then we'll touch upon some clinical here and there. Let's start immediately. In the forearm, we only have two bones, ماشي? So if you remember, in the arm, there was the humerus. Over here, we have two bones, the ulna and the radius. Both of these bones, they have distinct upper and lower ends and landmarks. So if you had a model in the lab, you could easily distinguish if this is the upper end or the lower end. We're going to talk more about them because these bones are going to be involved in two joints, the elbow joint and also the wrist joint. Between them, we're gonna have, between them, we're gonna have the interosseous membrane, which is a thick fibrous membrane connecting them to each other, okay? And again, about the articulation, it's the radius that is connected to both the humerus and the wrist joint. Meanwhile, the ulna is only connected to the humerus. Let's talk more about this. But before the articulation of the elbow joint, let's first talk about each bone on itself. Over here, we have an ulna. Now, the ulna has these landmarks, and they are important to know for your OSPE and for understanding. We have something called the olecranon, which is this posterior, like posterior thing. And then we have the coronoid process, the trochlear notch, which is right over here. And then we have the styloid process of the ulna, which is in the distal aspect. Hello. Why are these things important? Because they are going to, certain things are going to articulate with the humerus, and certain things will be involved in the wrist joint as well. So the ulna is special in which it's not involved in the wrist joint. What is involved is the radius. Like, what does the ulna do? It's separated by a disc. And we'll talk more about this later on. But before that, let's just appreciate these models a bit more. You can clearly see the olecranon over here, the trochlear notch, and the coronoid process. Mashi. So the coronoid process is more anterior. And if we look at our arms, it will be more anterior. Meanwhile, the olecranon will be more posterior. Tamam? And maybe in the OSPE, they will ask you to identify whether it's a left or a right. So familiarize yourself with everything. Mashi. Again, remember your ulna is on the medial aspect of your forearm. Mashi. Now the radius, your laptop connecting. Now the radius, we have only these two landmarks specifically, which is the radial tuberosity and the styloid process distally. And if we look more at the distal radius, when it articulates with the wrist, we have two like unique parts. We have a triangular part right over here. You can see the border, it's like a triangle. And we have a quadrangular part. But each one of these two parts will articulate with a different carpal, and they will form the wrist joint. We're going to talk more into details about the wrist joint when we reach the hand, but for now, just keep these in mind. And this is how it looks. So this is the proximal part, and over here it's the distal part. Again, familiarize yourself with them, and remember that the radius is located on your lateral aspect of the forearm. Now, because we're talking about the radius, we can also talk about Colles fracture, which is the fracture of the distal radius, or sometimes the radial styloid, which is also located in the distal radius. Eltayeb. So why is Colles fracture famous? Or like, why is it infamous? Basically, because it can affect the median nerve. Now, the median nerve will go through the carpal tunnel, and when you have a Colles fracture, the median nerve is also very close to the radius. So before it goes through the carpal tunnel, right over here, if you have any form of injury, trauma, or fracture to the radius, it can very well affect this nerve. And you can have something called a dinner fork deformity, where your hand looks like this. When your hand is broken, and the wrist and your radius is also affected, your brachioradialis muscle, it's a muscle we're going to talk about later on, will be pulling your broken fragment. So it's going to be connecting, because it's called brachioradialis, it's going to be connecting to the distal aspect of the radius, mashi? So it's going to be pulling on the broken fragment, and it's going to also play part in making this dinner fork deformity shape. We're going to talk more about Colles fracture later on, because it's a very high yield concept. And something to orient you guys, my slides, I have referenced like the lecture up here. So if you keep track of the title up here, you can see which lecture we're talking about. Come on. Sometimes I brought things from other lectures into places where they make sense. And I added them to link ideas together. And also, if you realize, I color code some things. For example, all my nerves are in this orange color, and this dark red color is my muscles. And you're going to find more color coding as we get further with the muscles, arteries, veins, and so on. And we're going to talk more about Colles fracture, so keep it in your mind. Now let's talk about the elbow joint. you guys are probably bored by learning about synovial joints. And خلاص, you know what they made out of. They have a capsule, you have ligaments, you have collateral ligaments, and then you obviously have the articulating surfaces and so on. So let's just kind of speak the things you may not know about the elbow joint. It's a complex hinge joint. Why is it complex? Because it doesn't only allow for flexion and extension, it also allows for supination and pronation. We're going to talk more about this later on. For now, the main or like the things that the constituents that make up this joint are the humeral ulnar and the humeroradial articulating like areas. So for example, if we look at this Dr. Atif diagram right here, we have our ulna and our radius, right? So the radius will form the radio or the humeroradial joint, and our ulna will form the humeral-ulnar joint. And also between the radius and the ulna, we have a radio-ulnar articulation semi-joint, okay? It's a joint, it's a proper joint, but it's not really the elbow. Over here, we realize the things we mentioned before, the olecranon, the coronoid, and even the head of the radius, all of them are going to articulate with things from the humerus. So let's look into more detail. When we talk about the ulna, we mentioned three things, صح? We mentioned the coronoid, the olecranon, and the trochlear notch. So the coronoid from the ulna, we're gonna like attach or just have an impression on the humerus, and that is the coronoid fossa. And the olecranon will do the same. The olecranon will be from the posterior aspect, but the coronoid from the anterior aspect. And the trochlea, which is part of the humerus, will do the same to us. It's the other way around now. So it's going to form a trochlear notch, or like it is the impression done by the trochlea. So all of these are going to just fit neatly into each other like a cupping, and it's going to form this hinge joint. When we're talking about the radius, it's very straightforward. You just have the head of the radius and the capitulum of the humerus, which is very just chill. Now, again, we mentioned the capsule and the ligaments. So these are things you already know from synovial joints. So again, of course, you're going to have collateral ligaments. You're going to have the ulnar collateral ligament and of course the radial collateral ligament. And over here we have a special ligament, which is called the annular ligament. And we're going to talk more about what it does when we discuss supination and pronation. When we're discussing the ulnar collateral ligament, which can be also called the medial collateral ligament, it is composed out of three different parts. You can't really see it properly in this diagram. We'll have more diagrams coming up. But the ulnar collateral ligament can be also called medial collateral ligament. And the radial collateral ligament is also your lateral collateral ligament. Of what? Of the elbow. But again, don't ever mix it up. On your medial aspect is your ulna. On your lateral aspect is your radius. Tamam? They could try to confuse you in the MCQs and not write ulnar or radial. They will just write medial and lateral. And then we have something called bursaes, and Ahmed talked about them. But essentially, they are a cushion filled with fluid to ease with friction, okay? I think you guys discussed supraspinatus bursaes. We have also bursaes in the elbow, mainly the olecranon bursa. So again, the olecranon is somewhere over here. When you put your arm on the desk or wherever, you're applying pressure to the olecranon, and you have a bursa over there to relieve this pressure. Otherwise, your bone would literally get inflamed and wear off. So the olecranon bursa, I also have a diagram, I'll show you later, is the most important bursa to talk about here. Why? Because it can also become affected or abused. If we overuse it, essentially, we're going to have a condition called bursitis, which is inflammation of the bursa. For olecranon bursitis, essentially, when you put your hands on your desk or whatever, you're just going to feel very uncomfortable. It's doing the exact opposite of what it's supposed to do. Let's look at some diagrams. So over here, we have a nice diagram showing us the ulnar collateral ligament, which is again the medial ligament, collateral ligament. You can see more clearly here the anterior band and also the posterior band and even the transverse band. And this is the radial collateral ligament, which is the lateral collateral ligament. Do I have, okay, these are the same, and this is from Amboss. Do we have a good one for the annual ligament? I think it's later on. And if we look over here, this is the bursa. This is the olecranon bursa. You see how it is at the very corner, and it's basically just acting as a cushion. Otherwise, the sharp bone will just wear off with contact to surfaces. And if it's abused, it's going to get inflamed, and it's going to do the exact opposite. It's going to cause you pain and problems. And this is a nice diagram showing all the articulation from the medial side. So this is the ulna. This will be our olecranon. This is the coronoid. And you can see clearly this is the trochlea, and this is the trochlear notch. So if we look more medially, and if we, now we're oriented here, if we look more like heck, we're going to see clearly the coronoid fossa, and from the back we can see the olecranon fossa as it inserts. Now, we discussed the bones, and if you believe it or not, we're done with it. That's everything for your elbow and your ulna and radius for now. So let's just talk about the muscles. For your muscles across the elbow joint, it's a bit confusing. Why? Because I don't want you to think that the forearm muscles are causing the movement across your elbow. These muscles are causing the movement across your wrist. What is causing the movement across your elbow are the muscles in your arm. Okay, so when you're talking about elbow flexion, elbow extension, it's these muscles that are mainly working, not these muscles. But when you're talking about flexion of the elbow, we have three main muscles: bicep brachii, brachialis, and brachioradialis. And the brachioradialis is a weird muscle. It's an imposter. It tries to be in both compartments, in both the arm and the forearm. We're going to talk about it and explain it. And out of all these three muscles that will cause flexion of the elbow, okay, it's the brachialis that is the strongest. Mashi? And because we finished with flexion, what about extension? So, as my friend Ahmed said, it's the tricep, the three heads of the tricep, and the muscle, a small one called anconeus. I don't think everyone has anconeus. Maybe it was one of those weird muscles.
No, that's Humerus longus.
It was, I think, also anconeus. I read somewhere. So, on these, yo, fact check.
I'll flex it.
All right. So, on this diagram, we can see the flexors. So this is the bicep, the two heads of it. You can see one connecting to the coracoid and the other is going through the whatever Ahmed said. And you can clearly see the brachialis muscle, which is a bit deeper. And you can even see the tendon, which is going with the cubital fossa. Over here, so I was right.
Yeah.
All right. So yes, anconeus is a weird muscle, guys. The tricep brachii muscle, you can see clearly the three heads over here, and even the anconeus, which is inserting over on the ulna. Tamam? So these are for extension, this is for flexion. It's not waste so much time on this, because it's a very simple concept. When we talk about the elbow, what makes it a complex hinge is mainly the pronation and supination aspect. So we have these muscles responsible for the pronation, which is basically moving from this to this, right? And these muscles are your pronator teres and pronator quadratum. And then when you want to supinate, it's going to be the supinator muscle and the bicep brachii muscle. And I'm pretty sure Ahmed also discussed this. Guys, y'all are kind of lagging sometimes. Does everyone have the same problem? If you want me to repeat something, I can repeat it. Is everyone okay? And can everyone see my screen and hear me and see me?
Everything is fine from my end.
I think I'll just continue. If you guys want me to repeat anything, عادي, feel free, don't worry about it. طيب. We discussed pronation. These are the two muscles, pronator teres and pronator quadratum. From their names, it's very easy to memorize. Supination, you have supinator right here, and bicep brachii, which is up in the upper arm, as Ahmed discussed. And we'll talk more about supination and pronation. So, The humeral radial joint. So we mentioned the elbow is composed out of the humeral ulnar and the humeral radial. When we're doing supination, it is the radius that is moving around and over the ulna. Actually, it's not the other way around. The ulna is kind of just fixed in place, and it's actually the radius that is doing the supination, or sorry, the pronation and the supination movement. ماشي. Remember our annular ligament? As you guys can see, it's wrapped around the head of the radius, and it's allowing for this kind of rotation or like movement over an axis. Okay? When we want to do supination and pronation, it's the humeroradial joint working with the proximal and distal radio-ulnar joint. So these three joints will all kind of articulate around each other and form our movement. ماشي? It's a pivot type joint with a fixed axis. So it's just this rotation. Okay? And these are things I mentioned. Over here, you can see the quadrate ligament. ماشي? And it's essentially connecting both of the ulna and the radius just for extra stability. And if we look over on this diagram, you guys can clearly see the difference between supination and pronation, and even the mid-prone and supination position. So you see how the ulna is fixed in place, and it's the radius that is actually turning around. So you see how the annular ligament is wrapping around the radius, and then this is the axis. Now, when the radius just wants to pronate or supinate, it's just going to wrap around our ulna, and it's going to do the movement. And it's going to take with it all the muscles and all the skin and so on. تمام? This was so crazy صراحة to learn about, because I never expected my bone is crisscrossing over here when you're doing pronation. And if we look over here, we can see the distal and the proximal, well, not properly, but in المهم, we have a proximal ulna to radius joint, and we have a distal ulnar to radius joint. For all of them, proximal and distal ulnar radial joints, alongside the radio-humeral joint, كلياتهم, they're responsible. تمام? You can see the annular ligament over here, and you can even like notice the olecranon, the trochlear notch, more stuff. All of these diagrams, يعني صراحة they're for your own reference. يعني go through them, they're very nice. They have a lot of things. So we can now discuss a bit more about the elbow clinical. فما شاء الله, the elbow, because it's a very mobile joint and one of the most important joints, it's susceptible to many pathologies and fractures and so. We have nursemaid's elbow, posterior dislocation, epicondylitis, and olecranon bursitis and radial tunnel syndrome. We discussed olecranon bursitis, and of course you have these as well, but these aren't really important right now. We're going to focus more on these. Let's start with the nursemaid's elbow, which is basically a condition that is unique to kids, because in kids, their annular ligament and their bones in general, they're much weaker and more susceptible to a dislocation and subluxation. So let's say you yank out a little kid and you just try to raise them. So you basically pull them from their hand forcefully and strongly. You're not intending to hurt them or anything, but it's just that you yank them out, and what happens is the bone itself kind of falls out of its place because it's not as strong as in an adult. What is the difference between subluxation and dislocation? Basically, subluxation is just semi-dislocation. So you can clearly see here that the bone, yes, it's not in its normal place. It's out of the annular ligament, but it's still kind of more or less in the same anatomical position. And if my bone is here, I hope you can see it. My bone is here, and it's just kind of slipped here. It's still more or less in its place. We call this subluxation. That's if my bone goes like this, or goes like this لتحت. Now it's not in its anatomical place at all. You can clearly see here, it's even pressing on the skin. So now it's called a dislocation. Like what happens in nursemaids? Both. You first have a subluxation and a dislocation due to the forceful yanking or like the pulling on a child's arm. So should be really careful with kids. And it's essentially just the radial epiphysis that slipped out of the annular ligament. And very extreme cases, complete rupture of the annular ligament, sorry. What about elbow dislocation? Don't even ask about the spelling mistake here. Best, it's a simple dislocation due to trauma, ماشي? And most commonly, it's a posterior dislocation. Because think about it. Your olecranon and coronoid, yeah, they're very big structures. They are more easier to just dislocate لورا, posteriorly, rather than be anterior. Okay? So the most common type of dislocation, elbow dislocation, is posterior elbow dislocation. Radial tunnel syndrome, يعني more or less, your radial nerve will go, of course, laterally across your near your radius aspect, and it's gonna go through a tunnel, like we call it the radial tunnel. It's gonna pierce through, or like it's deep to supinator muscle. But it's basically if you just have any kind of inflammation or any kind of overuse of the muscles entrapment, it can cause radial tunnel syndrome, and you're gonna have weakness in the radial tunnel, the radial nerve function. So for example, the sensory aspect and also the extensor muscle aspect. And the same goes with the ulnar. It will go through the flexor, like carpal tunnel, let's call it. And you can clearly see it over here. It's running over the medial aspect, so over at the ulna. And the same story happens. So if you're gonna have entrapment or any kind of abuse to that area, you're gonna have also symptoms with the ulna. What about epicondylitis? It's something we're gonna discuss later. You have golfer's elbow and tennis elbow, and both of them we will touch upon in detail next. So now that we finished with the bones of the forearm and with the elbow joint, let's discuss the flexors of the forearm. Okay, guys, anatomy is صراحة very straightforward. All you need to understand is the naming, and you can grasp the function more or less. And also, you need to just familiarize yourself as much as possible with diagrams, with models, cadavers, whatever. We just practice, memorize the names and the function and the innervation. But let's talk about the flexors. In the forearm, you have two compartments, صح? You have the flexor compartment and the extensor compartment. The flexor compartment is broken furthermore into a superficial, intermediate, and deep. And they are all more or less coming from the common flexor origin in your medial epicondyle. Okay, so over here, this is your medial epicondyle. All of these muscles are originating and then going down your arm, your forearm, sorry. So let's talk more about each compartment, starting with the superficial flexors. In your superficial layer, you only have 4 muscles. And if you remember from your class, it was pass, fail, pass, fail. These muscles are your pronator teres, which is responsible for the pronation of the wrist, flexor carpi radialis, which will be responsible for also flexion of the wrist, and abduction of the hand, which is any lateral deviation. And you have something, a muscle called palmaris longus, which is not present with everyone, only some people have it. And it's essentially responsible for tensing the skin of the wrist and facilitating grip. So it's very connected to the skin of the palm, and it's for gripping things. That's why even like if you don't have it, it's not really a problem. Then you have flexor carpi ulnaris, flexion of the hand, and it's responsible for also adduction of the hand. And what do these, or like how does naming muscles work in anatomy? You start off with the function of the muscle, and then you will talk about possibly the insertion and then the origin, or more so or less. So when we say flexor carpi radialis, we are talking about the action, which is flexing of the wrist, and it's inserting into the carpi, which are the carpal bones in the hand, and it's originating from the radius. And same story goes for flexor carpi ulnaris, but it's originating from the ulna. هلا innervation, all of them except for flexor carpi ulnaris are innervated by median nerve. So flexor carpi ulnaris is an imposter here, and it's innervated by the ulnar nerve. بينما pronator teres, ulnaris longus, and flexor carpi radialis all by median nerve. And if we want to like discuss more details of more specifics, the median nerve will pierce through pronator teres. So let's say if you have entrapment or just inflammation of pronator teres, maybe due to overuse or whatever, you're going to develop something called pronator syndrome, which is going to compress the median nerve. Ulnar nerve will pierce through flexor carpi ulnaris. Okay, now it's very easy to remember because this muscle is supplied by this nerve, and this muscle is also supplied by this nerve. So median nerve pierces through pronator teres and can cause pronator syndrome, and ulnar nerve pierces through flexor carpi ulnaris. It has ulnaris as well in the name. And both of these are anterior, and in fact, they should be in the flexor compartment. You're not going to mix it up with like extensor carpi ulnaris or something. And the ulnar artery will lie between the tendons of palmaris longus and flexor carpi ulnaris. If we look over here, this is our flexor carpi ulnaris, and this is palmaris longus. So our our ulnar artery will be right over here. And the radial artery will course over here. I'm going to talk about it in a second. This is another image for your own reference. And let's move to your favorite image, which is pass fail, pass fail. This is the flexor origin, which is the medial epicondyle, and here is all these muscles coming from it. So pronator teres, and it's a short muscle, it's going to finish over here, and it's responsible for pronation across the wrist. Flexor carpi radialis, starting from the radius, is going to go, or like from of course the medial epicondyle, and then it's going to go to like the carpal and the radial aspect, and flexor carpi ulnaris will go through the ulnar aspect. And this is another image for you. You see how short pronator teres is. At the intermediate flexor, we have a muscle called flexor digitorum superficialis, and it's also innervated by the median nerve. And it's innervated by the anterior interosseous branch. What does it do? It's flexion for your digits. Let's think about the name for a second. So digitorum is your digits over here, and it's gonna be responsible for flexing them. How? We will talk more about it later. The final flexor layer, which is the deep, we have three more muscles: flexor digitorum profundus, pronator quadratum, and flexor pollicis longus. Another thing about naming, because you have a superficialis here, expect a profundus, which means deep. Superficial is very close to the surface, and deep is profundus and like below it. Pronator quadratum is called that because it has four like borders and does pronation. And flexor pollicis longus will flex your pollicis, which is your thumb. And because you have a longus, expect a brevis somewhere coming forward here. So again, what are the naming rules or something we call them? If you start with the action, so if it's a flexor, you start with flexor. If it's a pronator, and if it's an extensor command, you say extensor. If you have a superficialis, you also have a profunda, which is the deeper variant of it. If you have longus, which is the long strand or long tendon, you're going to also have brevis, which is short. These are the three rules to keep in mind. And for innervation, all of them are innervated by the anterior interosseous nerve, which is coming from the median nerve. And a special case over here we have with the flexor digitorum profundus, and no, it's dual supplied. Basically, you have two nerves innervating the same muscle. You have the ulnar nerve controlling the medial aspect of it, and the anterior interosseous nerve controlling or innervating the lateral aspect. So when you guys remember in the hand, I hope you guys studied your lecture, this basically you're going to have or notice that the ulnar nerve is responsible for your medial aspect or like medial digits, and your median nerve is responsible for your lateral digits. How does that work? It's basically through this. Your flexor digitorum profunda, because of its dual supply, the medial digits are going to be innervated by the ulnar nerve, and the lateral are by the median nerve. And you can see the muscle right here, which is number 2. You can see how each one of the tendons are going to a separate digit. So these 2 digits are by the median, and these 2 digits are by the ulna. So it's the exact specific tendon. When you trace it back to its origin, there you have the different innervation, not over here. And this is pronator quadratum, but you can't really see the borders. Because we talked about flexor digitorum, we have something called, or it's kind of special case going with them, which are long flexor tendons. And I added this here, but we're going to also discuss this later in hands. But essentially, I want you to know that, well, I kind of also explained it. But basically, your flexor digitorum profundus, again, will split into the 4 digits, right? What about superficialis? It will also do that. You have 2 layers for 2 different jobs that we're going to talk about later on. All of these tendons are surrounded by a synovial sheath that is filled with fluid to ease up the movement. So you're going to decrease the friction. And the entire system is also held by these fibrous ligaments to make sure to hold the tendons in place and not slip out of the intended movement. Tamam? You can have 2 clinical conditions associated with all of them. One is called tenosynovitis, and the other is called tendinitis. What is the difference between both? Basically, let's just understand the names. And if you just break apart the words, you can understand it. Let's look at both words from the end, which are itis, okay? So itis means inflammation. Tenosynovitis is inflammation of 2 things: the tendon, teno part, and the synovial sheath part. And meanwhile, in tendinitis, it's just purely the tendon. So if you have an inflammation or an infection or poison or whatever, and you have both the tendon and sheath affected, it's called tenosynovitis. And if it's only the tendon affected, it's called tendinitis. We're going to touch more on all of this when we discuss the hand and the flexion of the digits and details. But for now, just keep this in the back of your mind and to link ideas better. Remember when we talked about epicondylitis? We said we're going to discuss it later. So we have 2 versions of it, right? One is golfer elbow and the other is tennis elbow. Now, both of them kind of or more have the same pathology pattern, which is basically just inflammation of a common of a common group of muscle. And when you talk about golfer elbow, it's the medial epicondyle. And what did we say about the medial epicondyle? And no, it's the origin point of the common flexor the common flexors of the forearm. So when we're talking about all the superficial group and even parts of the flexor digitorum superficialis, they all originate and arise from the common flexor origin. So if we have inflammation or abuse or trauma to that point, we're going to present with a condition called golfer's elbow. Okay? And it's very painful. It's very even sometimes just you can't perform many actions with your hand. And it's not really an emergency, but it's something that needs and requires some, support strains and also some physiotherapy. This is golfer's elbow, and it's related to the flexor compartment of the forearm. Let's talk a bit more about the innervation. So we said that what innervates most of our flexor compartment is our median nerve, right? And from the median nerve directly, we're going to innervate these 4 muscles: plantar teres, flexor carpi radialis, palmaris longus, and even flexor digitorum superficialis. From the anterior interosseous nerve, we're going to give out, it's a branch that comes out from the median nerve trunk, and it's going to give out branches to the deeper compartment. So we said half of flexor digitorum profundus, which is the lateral half, and we're going to also give out to pronator quadratum, and also we're going to give it out to flexor pollicis longus. What about one muscle from our flexor compartment, which is flexor carpi ulnaris? We mentioned that it's innervated not by the median nerve. It's innervated by the ulnar nerve. تمام? Keep that in mind. And what happens to the nerve then? It's going to give us a palmar cutaneous branch, which will go like very distally. It's a very later branch. And it's going to innervate part of the skin in our hand. Right? We're going to discuss this later on. And keep this in mind again, that the median nerve runs through and pierces through pronator teres. So pronator syndrome, in case of entrapment, could affect median nerve. And I think over here, I mentioned that, yeah, okay, this is, it's just the median nerve. It's not the anterior interosseous nerve, tamam? So I'll fix this and send it out. Over here, we have a very nice, like, diagram. And it's showing us all of the branches of the median nerve. So it's coming from the brachial plexus, and then over here it's going to give us a branch to pronator teres, a branch to, let's read them out. So carpa radialis muscle, longus palmaris longus, and even flexor digitorum superficialis, right? And then these are coming from the anterior interosseous. So flexor digitorum profunda, flexor pollicis longus, and even pronator quadratus, right? So all of these are the motor branch from this nerve. What about the sensory innervation? Well, we said it's going to give us a palmar cutaneous branch. Very later on, it's going to innervate some components or like some of the skin in the hand. And also we have some more motor components in the hand, but we're going to discuss this later on. When we were talking about the quadratus, where was it? Right here. I never mentioned this, yeah. So pronator quadratum. It's a special muscle because it's holding both of your distal ulna and radius together. So when you are applying pressure or like applying your body weight over this region, it's this muscle that is holding them together. All right. So let's say you're doing push-ups. When you're doing push-ups, you're doing a lot of pressure over on your wrist, over on this region, right? So without the pronator quadratum, both of these bones would just, and alhamdulillah, I mean, God gave us a very strong muscle over there. Like, we talked and finished with the median nerve. Let's talk quickly about the ulnar nerve. It only innervates two muscles here, or like 1.5 muscles, which is flexor carpi ulnaris, and we mentioned that it also pierces through it, and also the medial half of flexor digitorum profundus. Tamam? Also, it has some like cutaneous innervation in the hand, but for the most part, this is what we are concerned with in the flexors. And this is another amazing diagram. So you could follow along the course on your own, tamam? And you can even see the cutaneous branches from here. So now let's move over to something called the antebrachial fascia. We're gonna start with the extensors of the forearm. So this is the first step of getting there, which is basically what would you like face or like find if you went even deeper than the forearm region? You're going to come across something called the antebrachial fascia, which is a deep fascia enclosing the forearm region entirely. Halla. Together with the interosseous membrane, which joins both the ulna and the radius, as well as the fibrous intermuscular septa, we're going to divide the forearm into two compartments, a posterior compartment and an anterior compartment. And also you're going to separate the nerves, the arteries, and the muscles. Tamam? هلا the interosseous membrane is very, very important. لأنه we said that it separates both of them and both compartments, and we said that it holds both bones very strongly together, right? هلا we have some arteries and some nerves that run very close to the interosseous membrane. We respectively have called whatever is anterior to it the anterior interosseous artery / nerve, and whatever is posterior to it the posterior interosseous artery and / nerve. The origins of all this will be touched upon later, ولأنه it's kind of it's not really the same. They're not all coming from one origin. You'll see, but keep this at the back of your mind. Now we're going to talk about the extensors of the forearm. As we went with the flexor region, we saw how it has three like layers. We had a superficial layer, an intermediate layer, and a deep layer. Over here, we just have a superficial layer and a deep layer. Maybe they like the muscles look more, or like maybe they're a bit more intimidating, but wallah, they're like much easier than the flexors. Salah, all the muscles are easy. You just need to understand the 3 rules I told you, and you're gonna know the function, and even kind of understand the origin, and the innervation also is very simple. So let's start with our superficial muscles. Now, the superficial extensor muscles, they arise from the lateral epicondyle. Remember how our superficial flexor muscles come from the medial epicondyle? Our superficial extensors, they come from the lateral epicondyle except for one, which is brachioradialis. Brachioradialis is a very weird muscle. Why? For 2 reasons. Reason number 1, it's not an extensor, but it's very close to all the other extensors. It's a muscle that actually flexes your forearm. Remember how we mentioned the flexion of across the elbow? Its brachioradialis was one of the 3 muscles. It does flexion of the forearm across the elbow joint, and also, like weirdly enough, because it's a flexor, it's not even innervated by the normal like flexor muscles. It's innervated by the radial nerve. Right? So keep these 2 facts in mind. It's weird from the flexors because it's innervated by the radial nerve, and it's weird from the extensors because it actually flexes the forearm, not it doesn't like extend or anything. And the rest of the muscles, they're very straightforward, and they're more responsible with the wrist joint. So you have extensor carpi radialis longus, extensor carpi radialis brevis. You have a longus, extensor brevis. You have something called extensor digitorum, and you don't have a profunda or superficialis. You only have one. You have extensor digiti minimi, which basically is the small pinky finger. And you have also extensor carpi ulnaris. And the special case over here, that the radialis, we have 2 heads, or like 2 different tendons, not heads, sorry. We have a longus and a brevis. Meanwhile, we only have a single tendon for the ulnaris, okay? And as we mentioned again, brachioradialis arises from the humerus. It's not coming from the lateral epicondyle, and it flexes the elbow, it doesn't extend. But all of these muscles are innervated by the radial nerve, specifically the deep branch, or you can call it the posterior interosseous. You see why I told you the naming over here is like to follow it is a bit could be confusing, because the anterior interosseous nerve comes from the median nerve. Meanwhile, the posterior interosseous artery comes from the radial. No, sorry, what am I saying? The posterior interosseous nerve comes from the radial nerve. But both arteries, they're coming, or they're both like they originate from the common interosseous artery, which is a branch from the ulnar artery. You see how everything is just coming together here? But we're gonna discuss this in detail. Don't worry about it. Hello. We have also, because it's the lateral epicondyle. Remember epicondylitis? We also have lateral epicondylitis, which we call the tennis elbow. We're gonna talk more about it later. We can have our models here show us the muscles. You can see brachioradialis, it's originating from the humerus, and it's coming all the way down. Then you have extensor carpi radialis longus and brevis. You see the long head and the shorter one. This is a lateral view, but don't worry about it. Over here we have extensor carpi ulnaris. This is the ulnar bone. Extensor digitorum, which is a bit right here, and it's going to all 4 digits. And then extensor digiti minimi, which is a bit deeper, going to the pinky finger. And then when we talk about the deep extensors, we only have 5 muscles. So in the superficial extensor compartment, we have 6 muscles. In the deep, we have 5. In the flexor compartment, in total, we have 8. So count the muscles with me, guys. We have 8 flexors and 11, yeah, and we have 11 extensors. So subhanAllah, in your forearm alone, you have 19 muscles. SubhanAllah, this صراحة blew my mind. What are the deep extensor muscles? You have supinator, which does supination, believe it or not. Abductor pollicis longus, and you have abductor pollicis brevis, but it's somewhere else, okay? Don't concern yourself too much about it. Extensor pollicis brevis and extensor pollicis longus, which are very self-explanatory. They're going to extend your thumb. An abductor is going to abduct your thumb. And extensor indices. What is indices? It's your index finger. So it's going to be responsible for the super extension of your indices. What is the innervation? Radial nerve. Simple. The extensor is much, like the innervation is much more straightforward rather than the flexor compartment. Now, special things over here. You use your extensor indices when you pray, when you do the shahada, when you're in ruku'. And this is just a fun fact. It's not going to ask you on it. And supinator is, as my friend Ahmed said, it makes up the floor of the cubital fossa. ماشي? Keep that in mind. Okay, it's an extensor and it's also innervated by radial nerve. Over here we can see the muscles more. Let's first look over here. This is supinator. You can see it how it's wrapping around both the ulna and the radius, so it's responsible for like the supination movement. You have abductor pulsus longus and extensor pulsus brevis, longus, and even indices. You see how it's going specifically to the index finger. So you have digitorum going to all four, and then you have also indices backing it up, going straight to the index finger. This is another view of these muscles. So this is indices, this is extensor pulsus longus, this is extensor pulsus brevis. You can see how much shorter it is, and even abductor pulsus longus. Hello. This wasn't discussed in the lecture, but it was mentioned much further, but just keep everything connected. So if you have a mallet finger, or like it's injury common to baseball players, where their part of their like most distal finger gets jammed between the stone. I don't really play baseball, but you get the idea. Basically, it's gonna form hyperflexion of the distal joint, and it's gonna rupture the extensor digitorum tendon. Okay, and it's an avulsion fracture where you're just gonna have nothing really holding the very end of your finger. Tamam? So keep this in mind. We're gonna also discuss it later, but this is where you link it with extensor digitorum tendon. Tennis elbow, we talked about it a little. So it's gonna be inflammation inflammation of the lateral epicondyle. Tamam? هلا repeated forceful flexion and extension of the wrist, or basically when you abuse the muscles of this region, you're going to develop this symptom, this condition, sorry. And it's very common, by the way. Again, it could be very restricting your movement and daily activities. So you need to be careful when you do the repeated movements of, for example, doing a screwdriver, like if you're working in recall or like carpentry and so on. So when you use a screwdriver so much, you're abusing this, like all of these muscles at once. So you need to be careful, you need to rest up, and you don't need to overexert yourself. Halla, what comes from the lateral epicondyle? We said that what arises from there are the superficial extensor muscles. So you're going to see it. Extensor carpi radialis longus, brevis, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris. What about brachioradialis? It's also there. No, that is coming from the arm. Okay, it's coming from your humerus. That's where its origin. So it's not affected here at all. And a clinical presentation, you're going to have, of course, the pain and just the discomfort over that region. And it's exaggerated or very specially felt when you're doing activities such as lifting a glass or a cup of water, and even trying to open a door because you're using all of these muscles. Tamam? So keep these two details in mind because they could bring them up in your SAQs or even your MCQs. Now, remember how we talked about the median and the ulnar nerve and the flexors? Here we only have the radial nerve. The radial nerve is going to supply all of our extensors, and it does so after it pierces through supinator. And that's going to give us a superficial branch, and this superficial branch, any superficial branch, will go to innervate the skin. It's going to be a cutaneous branch. Tamam? And also it's going to become the posterior interosseous nerve. The deep branch, which is the posterior interosseous nerve, is going to, again, all of the four, it's going to innervate all of the deep extensor muscles and the forearm muscles in general. The superficial branch is going to go to the hand and innervate the dorsum. The posterior cutaneous nerve is going to be responsible for the cutaneous innervation of the posterior aspect of your forearm. Over here we have a nice diagram also showing us. These are the muscle branches And these are the cutaneous branches, the sensory innervation, تمام? You can clearly see how it's in the posterior aspect. Oh, this is another diagram showing us the cutaneous innervation. هلا, we kind of finished the forearm, so let's discuss the total skin innervation. We mentioned right now the radial nerve, right? So most of the posterior aspect of our forearm is innervated by the radial nerve, and even some part of the posterior aspect of the arm. ماشي? هلا, as my friend Ahmed said, the musculocutaneous nerve will innervate the lateral aspect of the forearm. Like, what about this aspect, T1? What is T1 here? What is the medial aspect of the forearm going to be innervated by? It's a nerve called the medial cutaneous nerve of the forearm. تمام? So what are you responsible to know? You need to know the posterior innervation, the medial, and the lateral innervation. Lateral is musculocutaneous, anterior medial is medial cutaneous nerve of the forearm, and posterior is the radial nerve. تمام? This slide صراحة is just something that Dr. Olina had, and she was so proud of it, حسيت. She really liked it. So 3 nerves, 3 muscles. تمام? It shows us here and highlights all the entrapment syndromes that could happen. So what are the 3 nerves that course through the forearm and then reach the hand? We have the radial nerve, ulnar nerve, and median nerve. طيب, radial nerve will pierce through supinator muscle. تمام? It supplies it, so it makes sense. Ulnar nerve, we said, it supplies in the forearm region 2 muscles, flexor carpi ulnaris and the medial aspect of the flexor digitorum profunda. That's a deep muscle. It's not going to pierce through that, but it's going to pierce through flexor carpi ulnaris. And median nerve will pierce through pronator teres. If you have entrapment there, we call it pronator syndrome. So 3 nerves, 3 muscles, and Dr. Lina is very proud of this slide, I feel. What about blood supply? We talked about innervation, we talked about muscles. Let's quickly brush over the blood supply. Let's talk with the veins first, and so they're more simple, and then we're going to go into detail with the ulnar and the radial arteries. Of course, we have both of these arteries supplying it. But when we talk about the veins, we have deep veins and superficial veins. And what you see normally, like when you go out in the sun and you see veins over your arm, these are the superficial veins. And then you're going to have accompanying veins to the arteries, which are the radial and the ulnar veins. So you're going to have 2 of each. تمام? And they're going to be tributaries of the brachial veins. بعدين, they're going to form brachial veins afterwards. بعدين, your superficial veins are 2 as well. You have the basilic vein, which is medially, and the cephalic vein, which is laterally. So if we look over here, we said that the medial aspect is going to be the basilic vein, and then over here laterally will be our cephalic. هلا, they are joined as well with the they get joined with the median cubital vein over the cubital fossa, and then they will all drain eventually to the vein. Let's talk about the arteries now. This is the same diagram we just looked at before. For the radial artery, it's one of the 2 arteries that is very important here. It courses. Let's just talk a bit about the coursing, and let's see. You don't really need to know all the details of the path it takes and so, and where it goes and where it starts. But have a general idea about it. Just know مثلا the most important things. For example, it lies between flexor carpi radialis and brachioradialis tendon, because some of these have a significance, and I'll show you what I mean by that. فالمهم, it will course under our brachioradialis to the distal forearm, so it's a lateral artery, and it's called the radial artery because it also follows the radius bone. تمام? It will then go all the way to the wrist. It will go through both, or between the tendons of flexor carpi radialis and the brachioradialis tendon, and then it's gonna wind dorsally through the anatomical snuff box, reaching finally the dorsal of the hand, piercing the first interosseous space. You don't really need to know that. بس المهم, you need to know that it goes through the anatomical snuff box, and that's between these 2 tendons. Come on. Most importantly, it will form our deep palmar arch. What are the palmar arches? We're going to discuss them in details when we reach the hand. Let's try and follow our radial artery from here. But we have the brachial artery. It's going to give us the radial and the ulnar artery. صح? The radial artery will go all the way here. Will go underneath the brachioradialis. And then it's going to be between brachioradialis tendon and flexor carpi radialis tendon. ماشي? Before going into the anatomical snuff box supplying the hand region. طيب, let's talk about some branches. So we have, of course, some forearm branches, which are the muscular and cutaneous. You have also the radial recurrent artery, and you have the carpal branches and the deep palmar branches, or the arch deeper, in the hand. What is the most important of all of these branches? The deep palmar arch. Okay, it's very important. We're going to talk about it later. The radial recurrent artery. Let's explain what recurrent means. Recurrence, can we even see it over here? I don't think so. Basically, a recurrent artery, you have a general flow of arteries. So like if you have an artery that goes downward distally, it's rarely to see it kind of like revert and do a U-turn back proximally. So that is what we mean by recurrence. There's a branch over here coming from the radial that is going to go do a U-turn and come back. Why does it do that? Hold on to that thought. We're going to discuss it. Why did I ask, or not, why did I say that you need to know, and it lies between flexor carpi radialis and brachioradialis tendons? Because when you want to measure someone's, when you want to measure someone's pulse, and you look for their radial artery, it's important to just locate these two tendons, and you can then immediately feel the pulse. So you're gonna have brachioradialis tendon, then the the flexor carpi radialis tendon right here, and it's gonna course through between them. So you just put your finger over and you're gonna feel the pulse. The ulna is on the other side, but it's not as important. We usually just refer to the radial pulse. The ulnar artery is kind of the same story. It's gonna be, again, you don't really have to know all of the path and the course. Let's know these two things, and it's gonna go through something called Guyon's canal alongside the ulnar nerve, and then it's gonna supply the hand structures, and it will also give us the superficial palmar arch. All of this is for your understanding, but for the most part, know that it is accompanying the ulnar nerve, and both of them will go through a structure called the Guyon's canal that we will look more at later on. But how is it different than the radial artery? It's different in the sense that the radial artery doesn't have an accompanying nerve going through it. بينما the ulnar artery goes along the ulnar nerve. تمام? What are the branches? We mentioned the superficial palmar arch, but you also have the anterior and posterior ulnar recurrent. So again, you have this recurrent arteries over here. Muscular branches to supply the forearm muscles. And you're going to have the common interosseous, if you remember, I mentioned it. And then the carpal branches near the wrist and the superficial palmar arch in the hand. What will the common interosseous do? Let's explain this. For the common interosseous, because it's common, it's going to split into two branches. It's going to give us an anterior branch, an anterior interosseous, and a posterior interosseous. And where is the interosseous membrane located? It's located between the ulna and the radius. صح? It's a very deep structure, and these arteries are the deepest, because they're lying very adjacent and close to this membrane. فهلا the anterior interosseous artery will supply what? The anterior compartment, which is the flexors. But like the deeper and most of the flexors come in, but mainly the deeper ones. What about the extensors? It's going to be supplied by the posterior interosseous artery, mainly again the deeper extensors. You need to know something important about these arteries. They're accompanied by nerves. They're accompanied by nerves that are also called the anterior, like the respective interosseous. So for example, the anterior interosseous artery will be accompanied by the anterior interosseous nerve. But this nerve comes from the median. And the posterior interosseous artery will be also supplied or accompanied, sorry, with the posterior interosseous nerve. But this one comes from the radial. So you get how everything is kind of just overlapped here, but please don't mix it up. It's very straightforward. It makes sense. طيب, let's just deconstruct each one alone. Let's talk first about the nerves. Where does the anterior interosseous come from? First of all, you have the interosseous membrane, and anterior to it will be superficial. Or not superficial, just anterior to it. تمام? But this compartment is the flexus compartment. What supplies here, or what's the main nerve here? It's your median nerve. صح? طيب, so it's going to be coming, it's a branch coming from the median nerve. And it's called the anterior interosseous nerve. بعدين, let's look at the posterior interosseous nerve. It's coming posteriorly to the interosseous, so this is the extensor compartment. What's our main nerve here? It's the radial nerve. صح? فهلا, this will be a branch from the radial, and this will be a branch from the median. What about the arteries? Both anterior and posterior arteries come from the nerve that is not dominant in the anterior or the posterior, which is the ulnar artery. You see the 3-in-1 situation we have over here? But practice this, try to link it with the muscles and the innervation and the actions to just not get them mixed up. تمام? Inshallah, it's very straightforward. Yani, the questions won't be tricky, bismillah. And lastly, we said both the anterior interosseous artery and nerve will supply the deep structures in the flexor compartment, and both the posterior artery and nerve will supply the deep structures in the extensor compartment. What about the recurrent arteries and everything that is weird over there? Halla, we have something special and unique with the elbow joint, which is basically something called collateral circulation. What does it mean to have a collateral circulation? Halla, usually an artery will branch out into capillaries, and then these capillaries will become veins. صح? That's the usual course an artery takes. But sometimes you have something called anastomosis between two arteries, where an artery joins with another artery. Why does it do that? Just to kind of overlap and share blood supply. So basically they would form a network of backup arteries. Tamam? This is basically what an anastomosis means, and this is the entire principle behind collateral circulation. So we are planning to have as much connections as much as possible. So in case of any obstruction or any trauma, another artery will just compensate. Okay? Because we have many important structures over here. We have important nerves, we have important muscles. So all of this is very crucial for our dexterity. So how do we do this? We do this with 4 main connections. First of all, let's recall our branches from the ulna. We have the posterior ulnar recurrent artery and the anterior ulnar recurrent artery. We also have superior ulnar collateral artery and an inferior ulnar collateral artery. طيب, هلا we're gonna have them kind of anastomose and connect in a weird way. The superior will connect with the posterior, inferior will connect with the anterior. Like so, let's look over here. This is our brachial artery, صح? This is our superior ulnar branch and our inferior ulnar collateral branch. They're both coming from the brachial artery. We said that the inferior ulnar collateral will anastomose with the anterior ulnar recurrent, صح? فهي رايحة هيك, and this it's coming down like this. We have a connection that is made. Let's say this gets obstructed and you don't have blood supply coming into this. Blood supply will flow like this and into the ulnar artery. So the inferior ulnar collateral coming from the brachial will anastomose with the anterior ulnar recurrent. What about the superior ulnar collateral that is coming from the brachial? This will anastomose with our posterior ulnar recurrent. You see the recurrence now? It's coming out of the ulna and it's going backwards. It's not going forwards. It's just going up. It's doing a U-turn back. And it's just connecting to do just more connections. Now we also have middle collateral artery and the radial collateral artery. And both of them are coming from the profunda brachii artery, which is the deepest brachial artery. Tamam? Now both of these will anastomose with the radial, or like one of them will anastomose with the radial recurrent artery that we talked about, And we also have an interosseous recurrent artery that's coming from the common interosseous. To recap, it's a lot, guys. Best try to memorize them. Maybe an MCQ will come on this. And it kind of more or less makes sense. Just know what each branch is coming from. You have the brachial artery, صح? Brachial artery will give you two arteries. So we'll give you the ulnar, the superior ulnar collateral, and the inferior ulnar collateral. Tamam? And both of these will obviously anastomose with ulnar, like ulnar branches. These ulnar branches are going to be the recurrent. So the anterior ulnar recurrent branch will anastomose with the inferior ulnar collateral. Saying ulnar too many times hurts. Posterior ulnar recurrent will anastomose with the superior ulnar collateral. This diagram صراحة is perfect. خلاص, it summarizes everything and try to just understand it, memorize it. تمام? What about our radial collateral and middle collateral? هلا, the collaterals, all of the collateral, ماشي, you see the collaterals, they're all coming from the arteries of the arm. بينما the recurrents are coming from the arteries of the forearm. فهلا, the radial collateral coming from the profunda brachii will anastomose with what? The radial recurrent. صح? Makes sense. What about the middle collateral? It's also coming from the profunda brachii. What does middle mean? It doesn't mean radial. Does it mean كمان, does it mean ulnar? Well, kind of. لأنه it's gonna anastomose with the interosseous recurrent. But where does the interosseous recurrent come from? It's coming from the common interosseous. Where does this come from? The ulnar artery. For the middle, it's just talking about the interosseous. You remember, the interosseous membrane is the most middle aspect. But yellow, without looking, guys. I said ulnar so many times, oh my God. طيب. You have superior ulnar collateral, which is going to anastomose with the posterior ulnar recurrent. This is coming from the brachial, and this is coming from the ulnar. Tamam? And then you're going to have the inferior collateral artery, ulnar artery, which is coming from the brachial artery, anastomosing with the recurrent, we said inferior, so with the recurrent anterior. Tamam? Anterior ulnar artery. The other two are like on the other side. So we're going to have the radial collateral, which will anastomose with our radial recurrent. صح? And then our middle collateral will anastomose with our interosseous recurrent. تمام? All of the collaterals that are coming from the arm will go down, up and down. بينما the recurrence coming from our forearms will only go up. Perfect. I hope this concept خلاص يعني it got through. And صراحة this slide was confusing for me too, but it made sense. Understood it. But this is again just talking what I said and the point of all of this. Know the profunda brachii gives what, know what the brachial gives what, know what ulnar gives what, know what radial gives what, and the common interosseous gives what. Tamam? Allen test. It's so straightforward and simple. Because we're talking about arteries, what if we want to check for the arteries of like the flow of the arteries of both the radial and the ulnar? Ahmed, do you want to try this?
Or
Allen test.
to show them? Or...
Yeah, and just like briefly. Let's not take so much time. It's like this picture right here. So you will tell the patient to first of all do a fist, grip so hard, and then let go. Now let go. And then I'm gonna just hold. Oh my God, I should have held before.
No, you hold before.
Yeah, I hold before. So I'm gonna press on both the ulnar artery and the radial artery. Now I'm gonna ask Ahmed to open. And you can see how the blood flow goes like normal. Like it's just small. Everything is just flowing normally and compensating. What was the word? Capillary refill, basically, is normal. Tamam?
Reperfusion?
Maybe. It's just capillary refill. That was what I was looking for. Both arteries are superficial to the flexor retinaculum. Why is that? We're going to talk about it later. Now, they said in their transcriptions that the angiogram is very important and you should know how to label all of them. Maybe it can come in the OSPI. Maybe it can come in your SAQ, like an obstruction or whatever. The brachial artery is over here. I know this isn't the greatest image, but this is what I got, okay? So you have the brachial artery, and then you have the split right here. So you have the ulnar and then the radial, tamam? The ulnar will be over on your medial aspect of the, remember, it's gonna course, alongside the ulnar bone, and then the radial will go across the radius. Tamam? You're not gonna be صراحة responsible for deeper like branches or like superficial arch because we're not experts and it's very hard. Let's move forward. So also you need to know these forearm cross sections. Yeah, and you don't really need to know each single detail. But always try to orient yourself and know what's the flexor compartment and what's the extensor compartment, because maybe they will ask you about the job of the compartment rather than the specific muscle. Tamam? So for example, you can easily identify the intraosseous membrane right here. So this should be the anterior compartment. These are flexors and these are extensors. Tamam? And everyone's favorite, compartment syndrome. We didn't leave it, we didn't forget it, so let's just briefly touch upon it. هلا compartment syndrome is essentially because of fascia. What is fascia? Fascia is this fibrous like cover that wraps around muscles. صح? Now, what's important about this fascia is that it doesn't stretch. طيب, if we have pressure buildup inside the muscle or like inside this fascia, how would that happen? Let's say, la samah Allah, we have like a swelling or a bleeding hematoma, whatever. So you're gonna have all of this fluid, edema, collecting up inside the muscle and pressing across the fascia. Now this fascia is not stretching, it's not going anywhere, and this fluid is not going anywhere. So what happens? It's just gonna press and cause inflammation, and then you're gonna have the death of the muscle. Your muscles will gonna also, like, under all this pressure and under your contraction and under your movement, will also exert themselves and they will physically rupture it. Well, it's catastrophic. So severe edema due to the buildup of the pressure could be also caused by chronic inflammation. So if you have many infections and they are not healing, tamam? هلا, you're gonna have compression of some like beside the muscle, you're also gonna have compression of some like contents. So if you compress the nerves, you're gonna lose sensation, and you're gonna even lose like the muscle actions. If you're gonna compress arteries, you're gonna block circulation, and this is catastrophic. You're gonna have death of the muscles and other like of bones and so and so. What causes compartment syndrome? Many things. It could be a fracture, it could be burns, it could be trauma. It could be a very badly bruised muscle that would cause a blood vessel to rupture, and then you're going to have edema and so. And even reestablished blood flow after blocked circulation, like for a long time. يعني لا سمح الله, if you haven't been mobilized and you're just sitting there in a coma or something, your blood supply isn't really reaching places. So if you suddenly increase the pressure there, you're going to cause edema, you're going to cause some kind of rupture. That can also lead to compartment syndrome. And how is it treated? Through something so صراحة like ghetto, I don't know, it's called a fasciotomy, where you just straight up rip the entire muscle and you just open the fascia up to just relieve the pressure. You're going to basically drain it. It's insane. But yeah, this is how it looks, and this is a fasciotomy. And then you're going to stitch it up with surgery and just you're going to make sure it doesn't happen again. We're done. Sorry. We're done with the forearm. Now we can talk about everyone's favorite, the hand. But if you guys have any questions, you can feel free to ask about the forearm or anything. If you guys feel we're going too fast or you want to ask any question from your own, تفضلوا يعني. Don't feel shy. Or if you want a small break, don't feel shy. And if everyone is good, we can just continue. I think we just continue. Yalla. So with the hand, it's the same story. We're going to discuss all of this and we're going to construct our hand step by step. So we will start with the bones, obviously. Now the hand is much more complicated than the forearm, where you only had two bones. Over here, we have three different groups of muscles, of bones, sorry. We have the carpals, we have the metacarpals, and the phalanges. So the carpals are very small muscles right here. Why do I keep saying muscles? Bones right here. And they are responsible for your like main formation of the wrist joint. Then the metacarpals are connected to the carpals, and the next like big thing. And then you have the phalanges, which are your actual fingers. So these are like, this bottom part isn't the metacarpal. The metacarpal is much deeper, and it's in your like palm. It's not even in your finger. تمام. هلا we call our phalanges by by relation. So we have 3 parts to each digit, and then the thumb is its own thing. So each part here, we call it like the most proximal is the proximal phalanx, the middle is the middle phalanx, and the distal is the distal phalanx. And then for the thumb, we don't have a middle phalanx, we only have distal and proximal. But we all, like for all 4, we have a metacarpal bone, and then we have a total of 10 carpal bones, or like 8 best, you have a hook and so and so. So let's talk now about the carpals. هلا we said that we have 8 carpal bones, صح? هلا I took this mnemonic from your transcription. I think it was by your BLC. So I guess I need to thank her for that. To memorize the carpal bones, because maybe they could ask you about any of them through an X-ray or through just a diagram, you need to just kind of memorize. So you can use a mnemonic. You could try to link it through anatomy. But for the most part, to be on the safe side, just memorize it from thumb to pinky and how it's laid out. You don't really have to build up your wrist, but just know the most important ones. Come on. We have 2 rows. We have a proximal row and a distal row. But when we talk about the proximal row, from your thumb to your finger, we have the scaphoid bone, the lunate bone, the triquetrum, and then the pisiform. Tamam? Which are like numbered right here, 7, 8, 9, 10. And then if we go to the distal row, we're gonna have our trapezium bone. Then we're gonna have the trapezoid. We're gonna have capitate and then hamate. Tamam? So again, let's go through the proximal and then the distal row. So we can use this mnemonic. She likes to play, try to catch her. She scaphoid, likes lunate, 2 triquetrum, play pisiform. صح? And we go from thumb to pinky. So scaphoid, lunate, triquetrum, pisiform. تمام? بعدين, when we go to the distal, she likes to play try to catch her. So we have trapezium, then trapezoid. And then catch her. So capitate, hamate. طيب. And when, like, maybe you mix up between all these T's, you have triquetrum, trapezoid, and trapezium. These 2, trapezium, trapezoid, and they sound similar, like similar to each other. فيعني group them together. They're going to be next to each other. تمام? بينما the weird one out, which is triquetrum, it's its own thing. And it's just weird like that. تمام? But trapezium and trapezoid are going to be also in your distal row because they're together and you have 2 T's in that sentence, try to catch her. بينما the first T, which is in the first sentence, she likes to play, it's in your proximal row. So that's triquetrum. So one last time, let's not waste so much time here. I think if I can go هنا. تمام. So without looking, this is scaphoid. She likes to play. صح? She is scaphoid. Likes is lunate. To play should be triquetrum and pisiform. And then try to catch her. So first comes trapezium and then trapezoid. So this is trapezium, this is trapezoid. Come on, you can kind of like see the outside borders of trapezoid. Try to catch her. So this should be capitate and this is hamate. طيب. Let's look more into these 2 bones. We said that this is hamate and we said that this is pisiform, or number 10 is pisiform. So hamate, we have like a hook to it, which we call the hook to hamate. And pisiform, we also have some kind of hook or like the entire the process is kind of hooking onto the triquetrum bone. فهلا, when we see both of these, when we see pisiform and we see the hook of hamate, we're looking at the palmar view. When we don't see them, you see here, we don't really see a hook, we don't see pisiform. We are looking at the dorsal aspect. Tamam? Keep this in mind. Over here, what is this? Is this a proximal or is this a dorsal aspect? This is pisiform, so this should be proximal. What am I saying? Ventral, palmar. And these diagrams are for your own reference. Tamam? let's talk about these, or like each single bone's clinical significance. We're gonna discuss lunate, hamate, and scaphoid. And the lunate is the most commonly dislocated bone of your carpal bones, tamam? And lunate is closely associated with the median nerve. So if we have a dislocation, it's gonna affect median nerve. Now we call this carpal tunnel syndrome. Okay? So what is the most commonly dislocated bone, Ahmed? It's the lunate. What about hamate? Hamate could be fractured because of its hook. So because it is a raised area and it has a because it has this hook, which is basically just an elevation or a raised area, it could be very prone to fracturing. It's not the most common fractured bone, but it's prone to it. So when it fractures, it's gonna affect the ulnar nerve because it's also closely associated with it. And it's gonna cause us something we're gonna discuss later, but keep this in the back of your mind. What about scaphoid? We said lunate is the most commonly dislocated carpal bone. Now scaphoid is the most commonly fractured bone. Tamam? And the most common way to fracture your scaphoid is through fouche, or is as it's abbreviated to, it's falling onto outward stretch hand or something like that. فالمهم, if your hand is stretched like that and you fall onto it and your scaphoid hits the ground first, it's very likely and highly likely it's going to fracture. Now, what is special about the scaphoid is that this is a medical emergency. Tamam? The radial artery is running through the snuff box and it's running close to the scaphoid bone as well. In an injury to the scaphoid, you can very easily, did I discuss it here? Yes. You can very easily obstruct the blood supply to the scaphoid. And this will result in something called avascular necrosis of the scaphoid. فهلا, the scaphoid blood supply is kind of unique. Now, what do we mean by that? Basically, the radial artery is going to supply it. But it's going to supply the distal aspect of it first, or more prominently. So you can see this is the proximal scaphoid and this is the distal scaphoid. And the artery is going to the distal first. The proximal isn't as vascular. So when you have a fracture and you have this blood supply which is completely broken or it's obstructed now, this proximal part is highly susceptible to something called avascular necrosis. What does necrosis mean? It's tissue death. So imagine your bone, just from a simple fracture, usually fractures, you can give them some time. They could just, they will not die as quickly. There's collateral supply and so. But the scaphoid is a special bone in the sense that a fracture here could cause avascular necrosis within hours. And it's very bad because if this is obstructed, your entire wrist joint is affected. Similarly, this could be seen in the head of the femur. I think you guys will study this lower limb. So again, you're going to have ischemia due to the loss of blood supply, and it's going to cause tissue death or necrosis. Metacarpals, nothing to talk about. Saraha, they just connect the carpals with the digits. Digits are very important for our dexterity. These are the names of them. You don't really need to know each one, but it's for your own reference. Of course, you need to know the pollex and digiti minimi. Indices, you have extensor indices. But what is important here, and you know how they are referred to, for the phalanges. So you have P1, P2, and P3, each for proximal, middle, and distal, respectively. And how do you, what's the anatomical relation to the digits? When you do the movement of abduction and adduction of your fingers, basically, you do it in respect and relation to your middle finger. So this is your axis. So can I have my digit pen? There we go. Over here, I have a digit. And this is my axis, right? So when I abduct, I'm going away from this axis. And when I adduct, I'm going close to this axis. So your middle finger, okay, has this job basically. So besides what it's used for, it has this job as well, where it's the axis for the abduction and adduction. This is how the carpal bones look on an X-ray. So this is, let's try to name them really quickly. This is scaphoid. So good mnemonics. She likes to play. So this is lunate, triquetral, whatever it's called, triquetral. Play, this is pisiform. And because we can see it, and even hamate, you can see the hook, this is a ventral aspect. This is like a palmar view. Try to catch her. So you have trapezium, trapezoid, hamate, and no, sorry, this is capitate and hamate. And this is how an X-ray looks like for the entire hand. This is like you can clearly see the carpals, the metacarpals, and the phalanges. And maybe they can show you an image in your OSPI, and you're responsible to name whatever bone structure right here. So be familiar with the X-ray, okay? Let's talk about the joints. You have many joints in your hand. So let's start with the wrist joint, which is the radiocarpal joint. Radiocarpal, so it's attaching the radius to the carpal bones, tamam? It's a complex type of ellipsoid synovial joint. So it has a lot of ranges of motion. You can do flexion, you can do extension, you can do abduction, adduction, and even circumduction. Tamam? The flexion and extension is usually done in this joint, but you also have other joints helping with these movements. So for example, when you talk about extension, it's mainly the radiocarpal joint. But when you're talking about flexion, it also occurs across the mid-carpal joint, which is connecting carpals to carpals. Let's show you that later, but let's first talk about the ranges of motion. But we mentioned flexion, extension, abduction, and adduction. And for each, a specific group of muscles is responsible for these movements. So over here, I kind of just listed them out all for you, and they all make sense. What did we say for our flexor compartment? We have flexor carpi ulnaris and radialis, صح? Now, these two, their main function is to flex the wrist. تمام? You see how the wrist is flexed? It could be like this, or it could be like this. When you do whenever you want to do a forearm exercise, this is not forearm, right? When you do this form of exercise, when you do bicep curls, you're training your arm. But when you want to do a forearm exercise, you do this, or like you just grab it down, tamam, or like you do wrist flexion. صح? So you have flexor carpi ulnaris, flexor carpi radialis. Flexor digitorum superficialis assist. It's not mainly responsible for flexion. Extension is the same story, but it's on the extensor compartment. So you have two radialis, longus and brevis, and you have one ulnaris. And extensor digitorum also is only assisting. It's not the main function. Abduction and adduction is kind of unique. So it's responsible, or like what is responsible for it are both flexors and extensors. And it makes sense if you just do it on yourself. For example, when I want to abduct my hand, I want it to get away from me. But when I'm abducting it, it's the muscle groups on my lateral side. So it's my flexor lateral and my extensor lateral. What are these lateral muscles? My flexor carpi radialis and both my extensor carpi radialis longus and brevis. When I want to adduct my arm, when I want to adduct my hand closer to me, it's my medial muscle groups right here. So it's going to be my flexor carpi ulnaris, and it's going to be my extensor carpi ulnaris. Tamam. What about circumduction? All of them. Now, let's talk about the radiocarpal joint, like its anatomy. Remember this picture I showed you back when we were talking about the radius? So over here, we said that it's a complex ellipsoid synovial joint. And again, it's a synovial joint. So of course you can have fibrous capsule, and it's going to be reinforced by ligaments, the ulnar and radial, collateral, blah, blah, blah. Okay, you know all this. What you don't know is that the wrist joint is including the distal radius, scaphoid and lunate carpal bones, and the disc to separate it from the ulna. Not a disc to articulate with the ulna, it's a disc to separate it, specifically just to separate it, because the ulna is not involved in making the wrist joint. فهلا, when we look at the distal radius, we said, if you remember back then, we have a triangular part and we have a quadrangular part. Big words. The triangular part is going to articulate with scaphoid, and the quadrangular part will articulate with lunate. You can see this, like the borders of it. So it's a triangle and it's a quadrilateral here. And when we see this is the distal, what do you call it? The distal ulna. You just have a disc. Okay, you don't have an articulating surface. You just have a disc that is going to separate it from being involved with the, what's it called? With the joint at all. Like I once, like if you were shown this picture, how is what is the orientation here? What am I looking at? What you're looking at exactly like from this orientation is basically looking thick. Tamam? Let's say you remove the hand, you're looking at the distal aspect of the radius and the ulna inferiorly. Tamam? When you hold a radius, or when you hold an ulna and you look at them distally, like from over here, you're gonna see a triangular and quadrangular articular surfaces on the radius and the disc on the ulna. Hone, you can see clearly the radial collateral ligament and the ulnar collateral ligament that is responsible in the wrist joint. You also have these where in your elbow, okay? So always specify which ligament you're talking about. There's a bajillion collateral ligaments. Always specify of the elbow, of the wrist, of the بطيخ, تمام? هلا, Colles fracture. We visit it again. We mentioned all of this, but let's just go over it again because it's the fracture of the distal radius, صح? We said that the radius is closely associated with the median nerve, so it could affect it when it fractures. And the scaphoid is also highly likely to fracture in a Colles fracture. So Colles fracture is usually fracture, yes, it is a fracture of the distal radius, but it's usually also accompanied by fracture of the scaphoid. And what did we say about fractures of the scaphoid? It's a medical emergency. You have avascular necrosis that could happen. Keep that in mind. And it's caused due to a Fuchs injury. The brachioradialis muscle will be the one responsible to pull the broken fragment. After a Colles fracture occurs, and after you stabilize the situation, you should do something called basically a neurovascular exam, where you are assessing for both the motor and the sensory components of all the nerves that are passing through the hand, because you need to make sure, or you need to diagnose what is affected and what is not affected. Inshallah, nothing is affected, but you can never be too sure. So you do this. Mainly with Colles fracture, it's the median nerve, صح? The median nerve has three components. It has a motor, sensory, and sympathetic component. But you can't really test sympathetic here. So what you test is motor and sensory. We know the motor and the sensory innervation of the median nerve, right? We said that it innervates the flexor compartment. If it innervates the flexor compartment of my forearm, is that helpful for me right now? Not really. لأنه in a Colles fracture, it's a distal injury to the median nerve. It's not a proximal injury. So this whole place, this whole area is spared from the problem. So what I should look for are the muscles in my hand that are innervated by it, which are mainly my thumb and my thenar eminence, and also some movements involving my lateral digits. Tamam? Sensory is also this innervation, my lateral innervation. So I'm going to feel, for example, pain and temperature, pinprick sensation, and so forth, to test for my sensory component. And you also have ulnar passing and radial nerve passing through the entire wrist. But when you have a fracture to the radius, which is very crucial to the joint, you just also check for them. You check for the radial nerve cutaneous innervation of the hand, and you can also run motor and sensory tests for the ulnar nerve. Like if you see over here, this is the cutaneous innervation. But this is the median nerve cutaneous innervation. I'm gonna test the patient to see what he can feel, what he cannot feel. And we do the same for the radial and the ulnar. I need to take like a second, طيب هلا حكينا and we talked and discussed about the radiocarpal joint. But I also said we have so many other joints going in our hand. These are all of them. We have the midcarpal joint, which is between the carpals and carpals. Carpal metacarpal joint, which is between the carpal and metacarpal. We have the metacarpal phalangeal joints, which is between the metacarpal bones and the phalanges. And then we have the proximal interphalangeal joint, which is between the proximal and the middle phalanxes. And then we have the distal interphalangeal joint, which is between the middle and the distal phalanges. And for the thumb, this is like you don't really have pip and dip, you just have an interphalangeal joint. So let's talk about each. In the midcarpal joint, which we mentioned before that it's also responsible for, or like it partakes in flexion of the wrist. You don't really need to know all this. Yeah, it's not really focused on in the lecture, but it's mentioned. And يعني هيك, just keep it in the back of your mind. So its outfit makes sense. يعني. We saw the radial collateral and ulnar collateral that are part of the radiocarpal joint. Come on, they extend to the midcarpal joint. You see over here how it's between the carpals. So it will be between the proximal row and the distal row. This is the distal row. تمام? Over here you can see the articulating faces and so forth. Of course, it's a Dr. Atif image. هلا, the movements that is allowed, you have flexion and extension, abduction and adduction, and they're all to varying degrees. But most importantly, it's stability at the wrist. If we move forward, we can. Carpal metacarpal joint is between the carpals and the metacarpals. And it's important because it's the main joint of our thumb. Yani one of the main joints of our thumb. For our main digits, for the most part, there's little to no movement. Yani it's a plain joint and it's not really allowing us for a lot of to express a lot of movement. But it's a saddle joint for our thumb, or what do you call it? Pollicis. So it would allow for the adduction and abduction of the thumb, and it will also allow for the opposition and reposition of the thumb. Let's zoom in here and look at them. So these are the carpal metacarpal, like the between the digits, and then this is the thumb one. You see how it's a saddle and it's very well different. Fahon is going to allow us to do these sorts of movements, which are adduction, or sorry, this is abduction of the thumb and adduction, and you're going to have opposition and reposition. Tamam? I'm not doing that. Wait, how do you do it?
This is the actual movements of the thumb, like this, not like this. You put your hand like this. This is abduction.
Oh,
So
okay.
this, like this, is abduction. And then this is flexion, this is extension.
Okay, flexion extension is later, but I just wanted to show them. So this is abduction, this is adduction. Tamam? And then opposition, we all know how to do it. Tamam? The metacarpal phalangeal joint is very important. It's connecting your metacarpals to the phalanges, and it allows for all of these. It allows for flexion extension of the thumb, and it also allows flexion extension of the digits across the lumbricals, and it allows for abduction and adduction of your fingers, and also relative circumduction. تمام? That's a condyloid ellipsoid joint. طيب مرة تانية, what did we say this joint is? It's a saddle joint. What did we say these are? Plain joints. These are condyloid ellipsoid joints. And this is how flexion and extension of the thumb would look like. تمام? As our friend Ahmed showed us. Interphalangeal joints are mainly for flexion and extension of the digits using, flexor digitorum superficialis and profundus. And from the back, the extension involves not only extensor digitorum, it also involves lumbricals, interossei, and extensor indices and extensor digiti minimi. تمام? هلا, this joint, يعني you should understand the ranges of motion across the joints. For example, when I want to flex my digits, صح? I can do this kind of flexion, which is across the interphalangeal joint, and I can do this kind of flexion, which is across the metacarpal phalangeal joint. طيب, when I'm doing abduction and adduction of the, of the digits, when I'm using my middle finger as the axis, I am going across the metacarpophalangeal joint. I'm not going across the interphalangeal joints. I can't, like this itself can't adduct and abduct. All it can do is extend and flex. But understanding the ranges of motion makes you understand the muscle more, makes you understand the bones more, the tendons, the synovial sheaths, and everything more. Yeah, you just understand it, understand this core very well, Salaha, and try to apply it as much as possible because everyone has a hand, I'm assuming. Yeah. Hello, we're done with the joints. We can talk some about the palmar aponeurosis. So basically, the palmar aponeurosis is connected to two things, proximally and distally. Proximally, it will connect to the palmaris longus tendon if it's present. We mentioned that the palmaris longus tendon and muscle, they are missing in some of the population, or they're not present in everyone. And the muscle anconeus is also the same. فهلا, if it's present, it's going to connect to the palmar aponeurosis. And distally, it's going to connect with the fibrous flexor sheaths of the fingers. تمام? هلا, the aponeurosis is present in everyone. And if you don't have a palmaris longus, doesn't mean that you don't have a palmar aponeurosis. No, you definitely have one. هلا, it also is between the thenar and the hypothenar eminences. And it's basically a thickened deep fascia to protect the blood vessels. تمام? Now, what's its significance? You have something called Dupuytren's contracture. I hope I pronounced it correctly. But basically, this is a condition which is more common in men older than 50, and it's usually bilateral, so both hands would express it. وكمان, it's not, we don't really know the cause of it. It's usually idiopathic. طيب? Most likely it has a genetic component. بس المهم, what it is essentially, it's just localized fibrosis of the palmar aponeurosis. You just have fibrosis, which is scarring of the tissue and just stiffening, which will then pull the like the metacarpophalangeal joint and the proximal interphalangeal joint of the fourth finger, which is annularis, and it's just gonna, I can't do it, but it's clear on the picture right here, tamam? It's just gonna pull it down and flex it and pull it into flexion. It can also sometimes involve your pinky. هلا, something to note here is that the distal interphalangeal joint is not affected at all, or not involved. What is involved is your metacarpophalangeal and your proximal interphalangeal. tamam? Again, this could happen to anyone. It's idiopathic and it's more common in men, not women, who are older than 50. What is the flexor retinaculum? So the flexor retinaculum is a structure in your palmar aspect of the wrist, and it's a tough fibrous connective tissue bridging the carpals together. طيب? So you have the carpals, and they're at the base of your hand, and they're forming like a tunnel. And then what forms the superior aspect of the tunnel is your flexor retinaculum. It's called flexor retinaculum because so many flexor tendons pass underneath it, and even you have the tendon of flexor carpi radialis coursing through it. Okay? Well, you don't really need to know the attachments medially, laterally, and صراحة it's just silly يعني. بس المهم, know that the median nerve courses underneath it alongside all the many flexor tendons that we're going to talk about in the carpal tunnel. Do we have an extensor retinaculum? Yes. Is it important? No. So we completely ignore it. You got a call. And you can see it over here. It's called extensor retinaculum. It's the same story where the extensor tendons pass underneath it, but it's not significant, and it's just for your own knowledge. It's just extra. Carpal tunnel. It's very high yield. It's very important, and it's very simple. So straightforward. You have 4 bones, or the carpals making the floor of it, and you have the flexor retinaculum making the roof of it. So this is the tunnel now, and coursing through it are 10 structures. You have 9 tendons and 1 nerve. What's the nerve? Median nerve, because it's called median nerve because it courses through the middle of the forearm and the wrist, right? So It's going to course through the carpal tunnel into the wrist, into the hand. And the tendons that are coursing through the carpal tunnel are the respective flexor digitorum superficialis and flexor digitorum profundus. And also you have flexor pollicis longus. So let's look over here. Flexor digitorum superficialis, it's on top, and then flexor digitorum profundus, and then this small one right here, it's flexor pollicis longus, and this is the flexor retinaculum. And you can see coursing through it is flexor carpa radialis. Halla, median nerve goes through the tunnel canal, and it gives out a superficial branch, a palmar branch, which courses not inside, courses up. So if we have carpal tunnel syndrome, we won't really have sensory deficits. We would have motor deficits. We'll talk more about this later. On, we have the ulnar and the ulnar artery and the ulnar nerve. We said that they course with each other. So we see that they pass over the flexor retinaculum, they're not inside of it. And I believe this is the radial artery. It's not accompanying the radial nerve. This is just to link everything we discussed previously. And again, this is to emphasize a point which no blood vessels run in the carpal tunnel. We only have 9 tendons and 1 nerve, which is the median nerve. So easy, okay? Now, I love this diagram so much. God bless ambos and Bilal Darul. So right here, we can see the flexor retinaculum also very clearly. And we can see the flexor carpi radialis and the tendons that are coursing through the carpal tunnel, which are flexor digitorum superficialis and 4 flexor digitorum profundus, and also flexor pollicis longus. And don't forget the median nerve. Now, what is this? What is this blue structure right here? We have the ulnar nerve, right? And the ulnar artery. If you guys remember, we said that they course together and they pass through something that we call Guyon's canal. So this is Guyon's canal right here. It's superficial to the flexor retinaculum and it's very like on the palmar aspect. What about the radial artery? It's right here and it's going to go through the anatomical snuff box, which is posteriorly or dorsally. And you guys can see clearly the cross section from where it's taken right here. Over here, we have more diagrams for your own, like, see. MashaAllah, it's a very high yield concept, but it's so straightforward. And even Atif touched upon it, Olina touched upon it, Atif touched upon it again. So, yeah, keep all that in mind. And we're discussing lunate dislocation again. So we called this lunate dislocation carpal tunnel syndrome, صح? Yes, we did. And it's basically the lunate bone dislocating and then pressing and compressing the median nerve. Because it's, if we go back here, where's the lunate? Scaphoid. Where is lunate? Over here, we can see it very clearly on X-ray. It's basically, it's kind of, I mean, it should be like just posterior, right? Now it's dislocated anteriorly and now it's compressing. So you have all these structures going here, and then this bone is pressing up and compressing the nerve. So the median nerve is affected. But as we said, because the superficial branch courses, the superficial branch of the median courses superiorly over the flexor retinaculum, it doesn't go through the carpal tunnel. So you won't really have sensory deficits through the median nerve. You will only have the motor deficits. So for example, the median nerve will supply this component of the hand, which is the thenar eminence. And you're gonna lose a muscle right here, which is called opponens pollicis, right? So when you lose the innervation to this muscle, you're not allowed to have this opposition movement anymore. So your hand is reduced back to an ape. What makes us different than apes is our opposable thumbs. So losing this opposition due to a distal nerve injury, which is caused by lunate dislocation, would yield in this result, and you see this deformity. And again, no sensory losses. Flexor synovial sheaths. And these are straightforward, come on. we have talked about the digital synovial sheaths, but let's talk about the entirety, like all of the wrist. But you need to know these three like rules. You have 4 digital synovial sheaths, you have 2 bursae, ulnar and radial, and you have 3 separate synovial sheaths at the wrist. You have the flexor carpi radialis sheath, you have the tendon of the flexor pollicis longus, and then you obviously have the common of the like long flexors right here. Now, what is important, what's the clinical significance of all this? Essentially, if you guys notice right here, this is continuous all the way down. And this is also continuous all the way down. These 3 are separate. And this is separate. So these 2, connected to the bursae, will have a pathway, a route that infections could take. طيب, لا سمح الله, you have an infection in your thumb and in your pinky. You may think it's simple and brush it off, it's just local inflammation. But you do have to treat it as fast as possible because it could, hypothetically speaking, spread all the way down to your forearm, causing you much worse symptoms. Because of this connection, existing connection with the pinky and the thumb, the infection could possibly trace down through the radial and ulnar bursae. And we call this phlegmona. I don't know if I pronounced it right, but this is how it's written. And it's in the flexor synovial sheaths. If you have a flexor, like a palmar cut in your in your pinky or in your thumb, this is a risk factor to this. So once again, infection may spread into the facial space between the flexor digitorum profundus and pronator quadratus. Where are we talking? We're talking right here. And then it could even spread more and deeper through your forearm. Okay, presenting with further complications. What about another synovial sheath clinical scenario? Now we talked about the flexor area, right? So you have the flexor sheaths and they're connected to the bursae and so on and so forth. 1, 2, and then all of these are these are 3 alone, and then there's another one right here. If we look in the other way, if we look at the extensor surface, we also have the same idea. We also have synovial sheaths there. But sometimes we can have weak points over there at the extensor surface. These weak points could rupture and could tear apart. When that happens, you can develop something called a synovial cyst. Okay? And usually, flexion and like doing a fist and so forth would cause more release and buildup of fluid on your dorsal aspect. So you see over here these 2 cysts. These are what we call synovial cysts. They are on the dorsum because it's the extensor surface, and flexing the fist could possibly increase them, make them more severe. Usually they're not tender. Usually they are painless. But sometimes due to forceful flexion contraction, they could become painful. Let's discuss the flexor tendons. This is very interesting and it's very important to understand. We have 2 flexor digitorums, right? We have flexor digitorum superficialis, which is supplied by the median nerve, and then we have flexor digitorum profundus, which is supplied by the median and the ulnar. Why do we have 2 flexor digitorums? It's not just because longus and brevis. There's actually a reason. It's profundus and superficialis. And we can see it more clearly right here. So the green tendon is superficialis, and we can see it because it's more closer to the skin. And the orange one is digitorum. It's profundus. Superficialis will go all the way through the carpal tunnel and then extend to the metacarpal, to the phalangeal. Once it reaches the proximal interphalangeal joint, it will split. And it will then insert into the middle phalanx. This splitting means that it's responsible for flexion across this joint, across the proximal interphalangeal joint. So if you want to do this movement, you see? What about this movement? Like if I want to do full flexion of even the distal interphalangeal joint. This is where the flexor digitorum profundus tendon comes in. Pierces through directly, goes through both tendons of the superficialis and inserts into the distal interphalangeal joint. فهون, when you're talking about flexion across proximal, it's mainly flexor digitorum superficialis. And when you're talking about flexion across distal interphalangeal joint, it is flexor digitorum profundus. تمام? Makes sense? I hope this is well explained. لأنه يعني it's a very important concept. إنه كمان this is very clinically significant مثلا in diseases such as osteoarthritis, rheumatoid arthritis. These joints are affected and you have even like nodules and so forth عليهم. It is very clinically important. You lose specifics of the movements. Understand this from now and keep it in mind. But once again, you're going to have flexor digitorum superficialis coursing through. It's then going to split into two. Where does it split? At the proximal interphalangeal. So right here it's splitting. كانت ماشية هيك واحد بعدين it splits. And then deeper to it will be flexor digitorum profundus coursing through the split superficialis and attaching to the digital interphalangeal joint. And again, everyone's favorite mallet finger, but it's not the flexor tendon, it's the extensor tendon. So again, hyperflexion of DIP would rupture the extensor. So if, like, think with me, if I keep flexing my finger right here, technically this puts strain on my extensor digitorum. So if this strain is like very severe, could completely rupture. طيب, now we're gonna finally talk about the hand muscles. فهلا, in the hand muscles, we have a couple of compartments and then we have like muscles for the fingers themselves. Besides, of course, flexor digitorum and extensor digitorum, what else? Let's talk about the muscles that you don't know about. For the thenar eminence, which is innervated by the median nerve, you're going to have these three muscles, and they're responsible for movement of the thumb. The hypothenar, which is located right here, is responsible for movement mainly of your pinky. Now, your lumbricals are mainly movement of your like digits, but in a specific manner. I'll explain it later. And your interosseous are for your abduction and adduction of your digits. And then you also have like adductor pollicis and palmaris brevis, because remember, you have palmaris longus. Of course, you can have a palmaris brevis. Let's look at each component alone now. At the thenar compartment, right here. Your lateral hand compartment, تمام? فهون you have three muscles, and they're all responsible or involved in your thumb. You have flexor pollicis brevis. Remember, flexor pollicis longus was in your deep flexor compartment of the forearm. You have abductor pollicis brevis. Remember, abductor pollicis longus was in your extensor compartment, I think the deep compartment. And then you have opponens pollicis. Opponens for your opposition movement. تمام? هلا, all of them are supplied by the median nerve. But why does the median nerve need to course through the carpal tunnel to reach these muscles and much more? هلا, you have something called adductor pollicis, which is this muscle right here. And it has two heads. It has a transverse head and an oblique head. And I'm pretty sure in the cadaver you can see it very well. هلا, this muscle is not supplied by the median nerve. It's supplied by the ulnar nerve. But it's technically and it's still in the range of the thenar compartment. It's its own adductor compartment. ماشي? Keep it in your mind. Over here, we have a nice model showing us the movements and the muscles involved, and also how the median nerve and the ulnar nerve courses. You see how the median nerve gives out main branches laterally? Because over here is your hypothenar, is your thenar compartment eminence. But the ulnar nerve is giving out medial branches, because over here you have your thenar, eminence. And you can see everything right here. This is adductor pollicis. And then you have abductor pollicis, and then you're gonna have brevis. This is opponens pollicis, And then these are both of your flexor pulsus brevis heads. Now let's talk about the hypothenar compartment, which will be your region right here. Tamam? Now your hypothenar, you have also three muscles. You have flexor digiti minimi brevis, abductor digiti minimi, and opponens digiti minimi. طيب. Flexor digiti minimi brevis. Where did we ever discuss a flexor digiti minimi longus? Here's the thing, we haven't, because it's not in the forearm. And I Googled this. Apparently it's an accessory muscle, so not everyone has it. And it's located in your wrist. Forget about it. Don't confuse yourself. خلاص, you have these three muscles for your hypothenar compartment. Flexor digiti minimi brevis, abductor digiti minimi, opponens digiti minimi. And it makes sense. This is your hypothenar, you're concerned with your pinky. This is your thenar, you're concerned with your thumb. What is the innervation? Ulnar nerve. Tamam? This diagram does the exact same. It's showing us the ulnar nerve, how it's coursing through. And over here, we can see abductor digiti minimi. Hold on. Abductor digiti minimi. And then we can see flexor digiti minimi brevis. We can see palmaris brevis connecting to the palmar aponeurosis. And this is palmaris longus. Tamam? And also you have opponens digiti minimi. Because you can do this movement. And this movement involves both opponens pollicis and opponens digiti minimi. Tamam? This is what makes us very dexterous. And the lumbricals. These muscles are found near your metacarpals. Tamam? And they originate from tendons of the flexor digitorum profundus. So you see how the flexor digitorum profundus, as it courses to get to where it needs to be, these muscles are coming from there. Mashi? It's like 1, 2, 1, 2, 1. Okay? You have 4 of them for every digit. And what's their function? Basically, flexion of the digits across the metacarpal phalangeal joint, like this, and extension across the interphalangeal joint. So imagine this muscle is doing both flexion and extension, but across different joints. Makes sense? So like this extension right here, this is the lumbricals, this is the interossei, this is extensor digitorum, and so much more. And this is flexion across metacarpal phalangeal joint. So when you do this, you're doing both movements at the same time. You're doing flexion and the extension. So we call this Z movement, which is right here. This, wait, what happened? Right here, you see this picture? Z movement. And it's completely opposite than claw hand. You're going to talk about claw hand in the brachial plexus path. What's the nerve supply of the lumbricals? Split. It's both. It's mixed. It's, if you're talking about the medial half, you're talking ulnar. If you're talking about the lateral half, you're talking median. Tamam? That's the deep branch of the nerve, sorry. Interossei. These muscles, we said they're responsible for your fingers' abduction and adduction across the axis of the middle finger. So you have 3 palmar. Oh, and they're split into palmar and dorsal, so anterior and posterior. And you have 3 palmar and 4 dorsal. And the palmar does an action and the dorsal does an action. So palmar, it's right here, it's gonna adduct. It's gonna bring them close to each other. I don't really have a way for you to memorize this. Salaha, for me, adduction is cute and abduction is like abducting a person, taking them far away from their parents and whatever. Dorsal sounds more mean than palmar. So dorsal is abduction. Palmar is adduction. Tamam? And both, akid, they participate in Z movement because they're responsible for also the extension of the shusma across the interphalangeal joints. Now, both of them, they're easy and nice because their nerve supply is the same. Ulnar nerve. Tamam? Let's zoom in right here at these models. You can see, so this is adduction, this is the palmar interossei, and we have 3 variants right here. Right here we have 4. This is the dorsal, it's abduction. Don't mix it up. The thumb, the thumb abduction and adduction, different muscles. It's not the interossei. When we're talking about the interossei, it's this. Tamam? Now let's move forth. And this is for your own. This is both the interossei lumbricals, all the muscle, the movements, so forth. Let's talk about the nerves of the hand now. Yalla, inshallah, we're gonna wrap it up. We just have the innervation left and the blood supply, and that's it. For nerves of the hand, all of these nerves coursing all the way down just to reach here, because this is where they actually do a lot of the things. But you have three nerves that we've been talking on and on and on about: radial, median, and ulnar, right? Halla, all of them are gonna innervate different components, as we saw. But let's recap with ourselves here quickly. The thenar component is innervated by median. The hypothenar is innervated by ulnar. These two lumbricals are ulnar. These two lumbricals are median. Now, all of these interossei are by the ulnar, and all these interossei are by the ulnar. Now, adductor pollicis, ulnar as well. Tamam? The three muscles here, which are the opponents and abductor and flexor brevis, median. And here you have flexor brevis as well, and also abduction and adduction. Kaman ulnar. Tamam? Tamam. Halla, let's talk about dermatomes a bit. Halla, you need to know these three dermatomes because they ask about them. I think for us they asked about the dermatomes in the toes, but for you maybe they ask about here. Come on, they highly likely said about the toes. So in your hand, you need to know these three dermatomes mainly. So C6 is the thumb, C7 is the middle finger, C8 is the little finger, your pinky. And more importantly, because the thumb is C6, so this whole area is C6, this whole area is C8, and this area is C7. تمام؟ I think you also need to know مثلا if you عندك then T1 comes in and then you have like C6 and C5. You keep the dermatomes in your mind. What are the dermatomes أصلا? They are a piece of skin, cutaneous innervation that is caused by a single dorsal root ganglion. تمام؟ who mostly is derived, most of the innervation, the median, ulnar, and radial nerves is derived from the T1 spinal cord. Let's finalize the median nerve. خلاص, we've been tracking it from the forearm, now we're in the arm. And we mentioned it already. It supplies these three muscles through its recurrent branch. تمام? And it also supplies the first and second lumbrical muscles, right? Now, we said it also gives a palmar branch, which will supply this area of skin, and it doesn't go through the carpal tunnel. It's superficial to the flexor retinaculum. You can clearly see it right here. This is the palmar branch. It originates before the carpal tunnel مرة, and then you have the median nerve coursing through the carpal tunnel. It's going to give us the recurrent branch right here to supply the thenar compartment, and then also it's going to give us the lumbrical compartment. تمام? تمام. Let's talk. I'll leave this for you, صراحة. We've looked at it before. Let's talk about clinical. We have two types of median nerve injury. We have proximal and distal. Why is it important? Because the clinical presentation is different and the clinical loss is different. But if we have a supracondylar fracture, as my friend Ahmed briefly touched upon, it's basically a fracture over the condylar processes. So the humerus is fractured over here, and it's gonna affect the median nerve because, of course, it's coursing through it. But this will obviously obstruct the flow of all the median nerve to the forearm and the hand as well. So you're going to present with something called benediction hand, where when you tell the patient to do a fist, they will do this. This is the best thing they can do. And the reason for it, because both of these are innervated by what? They're innervated by flexor digitorum profundus, right? And flexor digitorum profundus, like the lateral part, is innervated by the median. This is why they can't flex it. Also, these lumbricals are paralyzed, right? For Horn, you're going to have also the sensory loss, obviously, but mainly you're going to present with something like this, which is benediction hand, or hand of the Benedict, something in church. I'm not really sure. That's the muhim. You're going to have loss of flexion and opposition of the thumb as well, because the thenar compartment is lost now. The recurrent median nerve isn't going anymore. Unless it's obstructed, it's cut from here. But you're not going to have opposition. You're not going to have abduction or flexion. Like it's going to be very weak. You're going to have also, as we said, flexion, loss of flexion of the MCP. تمام. فهلا, what about a distal median injury? هلا, a distal median injury is not over here. So the forearm isn't really affected. But what is affected is the nerve coursing through the motor trunk that is coursing through the carpal tunnel. We talked about this a million times. It's the carpal tunnel syndrome. It's APAND. Reason for it is that the superficial palmar region is passing over the carpal tunnel, so it's not affected. This is why we only have a motor aspect here. And because of the recurrent branch coming after it passes through the carpal tunnel, this is why we're going to lose opposition. We're going to lose abduction and so forth. We're going to have APAND. You tell a patient to hold something with their thumb, they can't because they lost the opposition. صح? طيب. All of this is mentioned here, Tara. And this is the test for median nerve that I just demonstrated. And this is a table for you guys. Now we're going to talk about the ulnar nerve. The ulnar nerve, we just mentioned what it does. It supplies the hypothenar compartment. It supplies two of the medial lumbricals, the palmar interossei, the four dorsal interossei, and also the adductor pollicis muscle. تمام? And also it has a cutaneous branch, which will supply the medial aspect of the hand. What would happen? Again, we said that it's accompanied by the ulnar artery and it passes through Guyon's canal, superficial to the flexor retinaculum. Don't forget that, guys. And this is also for your own seeing. Now, what about ulnar clinical significance? Again, we also have a proximal injury and a distal injury. A proximal injury is going to be more problematic, right? But a distal injury is going to be more or less problematic. فهلا, the proximal injury is again a condylar fracture. Where? Medial epicondyle fracture. Yani beside all the problems that will cause for our flexor compartment, let's forget about that for now. Let's just only look at our ulnar nerve because it courses through what we call it, the ulnar tunnel right here, if you remember. But when we have a fracture of the medial epicondyle, maybe you fell on your shoulder, on your elbow like this, but you're going to affect your proximal ulnar nerve and you're going to present with claw hand. Why? Because claw hand is at rest, by the way. Like you remember benediction hand, they can do this, but when you tell them to do a fist, they can't. They will do this. بينما a person presenting with an ulnar problem at rest, they're like this. You don't even tell them to do a fist. They're like this. So this is median at rest. This is ulnar at rest. Okay? And then when you tell them, do a fist, this is median. تمام? هلا, you're going to have flexion weakness because of flexor carpi ulnaris. And also you're going to have radial deviation of the wrist because, of course, you're going to have the paralysis of flexor carpi ulnaris. So the flexor radialis and the extensor carpi radialis muscles will overwork. And they're going to just pull on the flaccid muscle. We're going to have radial deviation and claw hand. Claw hand at rest due to the paralysis of the lumbricals and also the interossei right here. The lumbricals are responsible for extension. So when you lose that, you're not going to have this extension anymore. You got me? This is what claw hand looks like. And the distal injury is the hook of hamate fracture. So it's going to affect the ulnar nerve because it's passing near it. And you're going to have claw hand as well. But it's not as severe. You're not going to have the weakness of flexion. You're going to have the radial deviation and so forth. And this is how you would test for an ulnar nerve. Because we mentioned that it's responsible for the interosseous, right? So you will tell a patient to hold something between his fingers. This is adduction. So if my muscle is weak or my innervation is weak, I won't be able to do this at all. This is for your own. And now we're going to talk about the radial nerve. Radial nerve is going to give us mainly a superficial branch, okay, in the hand. Because in the hand, none of these muscles are innervated by the radial nerve. It's purely cutaneous. As you can see, it's mainly in the dorsal aspect. The radial nerve will course through the anatomical snuff box as well with the radial يعني شو اسمه with the radial artery كمان. The way you would test for it, like let's say you want to check if what do you call it? Yeah, if you want to check for the integrity of this nerve, you would do essentially this procedure where you're gonna tell the patient to extend all of his fingers, and then you're gonna press down on these fingers. Because what is this muscle right here? This is extensor digitorum. It's the main muscle in extension, and it's innervated by the radial nerve. So this is the only muscle that's originating from the forearm, going all the way here from the radial and so forth. And of course, it also gives you the posterior interosseous nerve, which is innervating the extensor deep compartment. This is for your own look. The clinical significance here isn't really proximal or distal, it's just one, where you would have a wrist drop. Basically, none of your extensors are working, and it's your flexing. There's no opposed motion to the flexion, so your wrist is just dropped like that, you know? And there's inability to extend the wrist, paralysis of all the extensors, so forth. Now, this is the skin innervation of the hand, dorsally and palmar. The dorsally, let's look at this. We said that laterally, you're going to have the radial, and medial, you're going to have ulnar. And median is like the tips of the fingers, 3.5, so and so. But then when you have palmarly, the most lateral aspect and the medial aspect is the median nerve, and the very medial aspect is the ulnar nerve. What about the blood supply of the hand? So again, we have arteries and veins. Let's first talk about the veins because they're simpler. Remember in the forearm, we had two superficial veins, which were the basilic and the cephalic. So the cephalic is lateral and the basilic is medial. So when we're talking about, wait 1 second, someone's texting on the chat. All right. Yeah, sure. So when we're talking about the vein blood supply, because the basilic is medial, it's going to drain mainly the medial side. But when you're looking at the index finger and your thumb, which is laterally coursing, it's mostly drained by the cephalic, or it's going to go to the cephalic vein. And this is the rest is for your own reading. Of course, they're gonna end in the axillary vein very late. They're gonna join with the cubital, medial cubital, and so forth. See, medial cubital, and then they're gonna all tributary into the axillary and subclavian and the cubital. The radial artery and the ulnar artery both will end up in the wrist at the end, right? We mentioned about their collateral, we mentioned about their recurrent branches. What about the branches that go to the hand? Now we mentioned for the radial, it's the deep palmar arch. Now this deep palmar arch is the most important one, طبعا. But also you have dorsal digital, princeps, pollicis, and radialis indicis branches. The most important thing to look here, and then your deep palmar arch, it's obviously the terminal branch of the radial artery, or it's the direct continuation. And then it's going to anastomose with the superficial palmar arch coming from the ulnar artery. It lies on the interosseous muscle, and it gives rise to the metacarpal arteries, the palmar metacarpal arteries. If they were to ever ask you about the metacarpal artery blood supply, it's mainly the radial artery with the deep palmar arch. You can see it right here. It courses through and then to the snuff box. By then, it's giving you the arch. This is the deep palmar arch. And then over here, these are the palmar metacarpal arteries. This is the metacarpal bone. See how it's supplying it. So then you would talk about the snuff box. It's a very high yield concept, صراحة. You need to understand the boundaries and the contents. So it's straightforward, honestly. Don't stress too much about it. But the boundaries, you need to know the medial and the lateral boundaries. And you can very easily see it. or like identify them on yourself. But over here, this is the medial boundary, and this is the lateral boundary, and then this is the actual snuff box. Why do they call it snuff box? They snuff things from it. فهون, this would be our medial border, which is extensor pollicis longus. It's going to my pollis as extension, responsible for extension. And then over here, we have two tendons. We're going to have abductor pollicis, and we're going to have extensor pollicis brevis. Okay? Abductor pollicis and extensor pollicis brevis. فهلا, now that we mentioned the borders, let's talk about the contents a bit. So you're going to have the radial artery, you're going to have the superficial radial nerve branch, you're going to have the proximal end of the cephalic vein, and you're going to have the scaphoid and the trapezium making the floor of it, basically. So the radial artery will run through the floor of the high, and it's going to pass over the scaphoid bone, giving it, as we said, the distal branch that is going to supply the distal part of the scaphoid, leaving the proximal part prone to avascular necrosis. Tamam? This is your snuff box. It's relevant with your radial nerve. And this is more clearly the boundaries. طيب, I'm looking at it right here. How is this the medial border? It's clearly lateral. Well, you should look at it from supine position. So over here, it looks lateral. Like over here, it may look lateral to you. But once you flip your hand, this becomes medial. And this actually, I don't know if I'm even on camera, but this would become your lateral border. هلا, ulnar artery. We talked about the branches, the collateral, the recurrent. المهم, هلا, we're talking about the superficial palmar arch. Okay? We mentioned that with anastomose with the deep palmar arch coming from the radial artery, and then it will give us digital arteries. Okay? So we said metacarpal palmar arteries are coming from the deep, like the deep arch, بينما the superficial arch will give us the digital arteries, the common and proper palmar digital arteries. But once again, what is supplying your digits? It's the superficial arch coming from the ulnar artery. What is supplying your metacarpals? And what is supplying your carpals? Mainly the radial artery, where it's giving us branches to the carpals, and it's giving us the palmar metacarpal branches. Tamam? Very straightforward. Also, I included these images, but صراحة, I don't ever think they will let you guys try to identify the arch on a cadaver, but it's very straightforward. So you can easily know if something is palmar or dorsal, and then you see an arch, خلاص, superficial and deep arch على طول. This is all the upper limb blood supply. Indulge in this as much as you want. And over here, we can see a lot of the muscles, the radial artery, the ulnar artery. You can see the branches and so forth. And lastly, let's see what's remaining. Lymphatics. So, our all favorite lymphatics. Now, again, it's similar to it follows the veins, because laterally you're gonna have the basilic, and laterally you're gonna have the cephalic, and medially you're gonna have the basilic, right? So lymph vessels from the thumb and index, and the lateral part will follow the cephalic vein all the way into the axillary lymph nodes, apical axillary lymph nodes, and then your middle ring and little fingers, the medial part aspect, will follow your basilic vein more or less to the supratrochlear cubital nodes, which is right here, cubital lymph nodes. And lastly, they will, of course, drain into the axillary lymph nodes. I think Ahmed really touched upon this very well, I hope. Lastly, we have some clinical scenarios. Not scenarios, but circulation clinicals. One is lymphadenitis, which is basically just infection reaching the lymph nodes. They will enlarge, they will become tender, and they will be just very prominent. And we call this lymphadenitis. هلا, this would explain the frequency of inflammatory edema and even abscess formation. What is response like all of these words you don't really know much of. It's mainly in second and third year. But what you're responsible to know is how it looks, how it could present. So you can clearly see this finger is inflamed. you have probably an infection over here. And if you remember, this one, the middle finger wasn't one of those fingers that would end up in the forearm. This would, because it's the middle finger, it would drain into the basilic, like it will follow the basilic vein and then into the lymph nodes. But over here, we're gonna have some inflammation and tenderness, and we call this condition lymphadenitis. The other condition, which is more easy to see, Raynaud's disease. Raynaud's disease is very صراحة relevant in your second and third year, not really in your current year. You're gonna take it in MSI, and basically it's a peripheral vascular disorder. It's gonna be characterized by vasospasms, and it's due to cold or emotional stress. It's frequently seen in males and females, which are, let's say, you under an occupation with a very vibrating material. For example, you're using a chainsaw, you're using a drill, and so forth. So you're gonna have compromised capillary refill, and your fingers, your most distal aspect, will feel cold, will feel bland, and they are pale compared to the rest of your body. And with this, we conclude our long session. We have covered the following lectures in this crash out course, although I'm thinking I'm the one who crashed out. We have bones of pectoral girdle, joints of the shoulder region. These were covered by Ahmed, and these were covered by me, and we also kind of touched upon upper limb injuries. We have used these following resources, the 17th batch transcriptions. Thank you so much to both Yahyas, and even Yazan helped us with them. Amboss, thank you, Bilal Dawood, and Atif. The Atif Moodle tables were provided by Yahya Mutawalli. Thank you so much. And please scan the QR code for feedback. And lastly, thank you guys all for listening. We hope we have happy.
Yeah, I'm happy.
We hope you guys have benefit as much as possible from this. طبعا you can't really base all of your study on this. We try to include as much as possible. بس we're asking you guys to use this as reference for your studies. And the slides are the most important resource. They have everything in them. Use the transcriptions, use the recordings, whatever. Inshallah, everything is straightforward and everything works out at the end. But it has been a lot of fun planning this and working on all this. We hope we haven't really bored you guys with all the details, because anatomy is very صراحة pure and like just memorization and dense anatomy and action and function. To understand everything could be very tricky. Where can we see the camera?
For what?
Our camera.
Here.
Yeah.
Hey.
Okay, tamam.
Open chat.
So we want to provide you guys with some of your own, what do you call it? Like, these are for your own reference. These are tables provided by Atif, and we want to add even more things from models and diagrams. We will add this and then send this out again to you guys. For now, inshallah, you guys benefit as much as possible with us for however long we spend.
4 hours.
Gosh. Pad and dab work. What was pad and dab?
Dab, like dorsal interossei.
I see. So thank you so much. Best pad session ever. My way to see Dex. Thank you guys. And thank you guys so much for sticking with us. صراحة عذبناك.
لا, don't mention it.
Yeah, thank you guys all for attending, especially the third and the fourth year that are doing MSK with us, I guess.
Yeah.
Thank you guys so much.
Thank you. Take care.
Yeah, we're gonna end screen sharing.